first session would be taken by me on non-invasive ventilation. The second session would be by Neeraj sir on the basics of mechanical ventilation, and the final session would be by Dr. Arjun on monitoring and troubleshooting in mechanical ventilation. Try to share this.
Vineeth കാണാം.
തുടങ്ങട്ടെ നീരജ് സാറേ?
സ്ലൈഡ് ഷോ അല്ലേ?
അതെ,
സ്ലൈഡ് ഷോ അല്ലേ സാറേ?
സ്ലൈഡ് ഷോ കാണാം.
Okay.
So we start today's session. We'll be starting with non-invasive ventilation for today.
വിനീത് മൈക്ക് കുറച്ചും കൂടെ അടുത്തേക്ക് വിളിക്കോ, സൗണ്ട് കുറച്ചും കൂടെ.
ഇപ്പൊ കേൾക്കാവോ സാറേ?
കേൾക്കാം. ഓക്കെ, ഗുഡ്.
Okay. So we'll start with the case scenario and try to see how are we going to approach this patient. So what happens very commonly in our COVID wards, we have a 50-year-old man who became rat positive around 10 days back. He started having breathless on day 7 or something like that. Came to us, had a low saturation. He was started on nasal prongs, did not improve. Escalated to face mask, did not improve. RBM, and even with NRBM on a 15-liter flow of oxygen, his saturations were only touching 80. Patient was also breathless, so he was taken a non-invasive ventilation with a BiPAP machine. His settings were D mode, IPAP was 20, EPAP was 7. His respiratory rate is 40 and SpO2, but the SpO2 is still 79. What will you do? So this is a common scenario that we all face in our wards. What will we do with this patient? So probably there are two things that we need to think about this patient. We have a patient who has an organ failure, whose lungs are failing. And what is causing the failure of these lungs? The lungs are being failed because there is a cytokine storm that is happening. So you have to monitor the other systems along with that. But primarily, the two things that we are trying to monitor in the system is his lungs are failing. So you have to keep a watch on his saturation, or we have to keep a watch on his PF. And along with that, you have to, and what is causing these lungs to fail is a cytokine storm that is happening. And what will help you to monitor the cytokine storm is the inflammatory markers. So you try to do a CRP, an LDH, a ferritin, and a D-dimer on day 1. And a patient like this who's a category C, severe patient, becoming critically ill, you have to monitor these inflammatory markers every 48 hours to see how is are we able to control the cytokine storm or not? Now, just a word about pharmacological therapy before we go into how do we really optimize his respiratory therapy. Probably if we look into all the evidence right now, the drugs that have improved mortality are steroids. Whereas most of the other, even though there are a lot of drugs that are prescribed and written in guidelines and other things, we hardly have any solid data say that most of the antivirals are actually working. Remdesivir showed some improvement. There was a 4-day earlier improvement with Remdesivir, but still Remdesivir did not show any mortality benefit. So all these, we really do not have solid data to back up to tell us that antivirals will help us in saving this patient or will help us in improving mortality. The drugs that have shown improvement is the drugs that actually steroids recovery trial showed us that steroids improve. Steroids help help in decreasing mortality. The dose of recovery trial was a 6 milligram dose, but even we have patients like this who are actually on Dexona 6 milligram and still are not improving. The question is, should we actually increase the dose of steroids? And probably our Kerala guidelines tell us that we can, the dose of Dexona is 0.2 to 0.4. So maybe you can escalating the dose of your steroids. And after that, the other drug that has shown mortality benefit is tocilizumab. The recovery trial and remap cap trial, both these trials showed that there is statistically significant mortality benefit with tocilizumab. So if we are not able to control the cytokine storm with steroids, then probably there is a role in and if we see that the high despite and the cutoff that was used as an inflammatory marks for CRP or 75. So if we are seeing that the inflammatory markers are high, so probably there is some role for tocilizumab. So on one hand, we are trying to optimize and suppress his cytokine storm, and on the other hand, we are trying to optimize his the organ that is failing, the lung that is failing. Now the question is, how shall we optimize our failing lung? The two ways, now that we know that in saturation with an NRBM, the two options that we have are non-invasive ventilation and mechanical ventilation. Okay, so the question that we have to ask ourselves is, shall we take this patient on NIV or shall we take this patient on mechanical ventilation? Our experience over the last maybe 1.5 years, we have not been able to have very good survival rates with our mechanical ventilation. So, but whereas NIV has really helped us in patients. So the question is, so probably when we see a patient like this, when this is a window in which where that we see a patient, the two things that we can do is suppress his cytokine storm and optimize his non-invasive ventilation therapy so that he may not go in for a mechanical ventilation. So these are the two things. And so we will be trying to look at non-invasive ventilation. And the good part about non-invasive ventilation is that it has a very small learning curve. Maybe this class will actually, there's nothing much to learn about ventilation, whereas the learning curve for a mechanical ventilation is fairly steep. You have to really invest some time on it. Whereas NIV can be easily learned. That's a good part about NIV. But then there is something that has to be learned about NIV. And the most important problem in NIV is not how do you fix the Velcro, even though that is a major struggle that we always have when we first try to use a non-invasive ventilation. So we are seeing this patient. Should we consider taking this person for non-invasive ventilation? If our patient is having complaining of moderate to severe dyspnea, we won't be looking at type 2 respiratory failure because COVID ARDS is a type 1 hypoxemic respiratory failure. Patient is having moderate to severe dyspnea. His respiratory rate is more than 30. His sternocleidomastoids are working. So then you are worried of this patient. So you do a saturation, and if you want, you can also do a arterial blood gas. So just a word about ABG. It has not been mentioned till now. So if you are a person perplexed about ABG, just a word about PF ratios. Normal partial pressure of oxygen in the blood is 75 to 100, and you get a partial pressure of around 80 at an atmospheric FiO2 of 20. So when we are breathing at 21% FiO2, the PaO2 is 80. So now so the PF ratio is more than 400. A normal PF ratio is 400 to 500. So when we are increasing the FiO2 from 20 to 100, you are expecting the PaO2 to become 400 to 500. So if you are giving FiO2, if you are giving an NRBM, if you are giving a 15-liter oxygen through an NRBM, you are giving an FiO2 of around 90. And if you are giving an FiO2 of 90, the PaO2 that you will expect in a normal patient is more than 350. So if your PaO2 is not that high, if your PF rate, then you should consider going in for non-invasive ventilation. Before COVID times, we used to say that a PF ratio of less than 100 is a severe ARDS. We should go ahead with the mechanical ventilation. But now, because of the constraints of our institution, because of other constraints, because of the overall increased mortality with mechanical ventilation all over the world, all over the worldwide, probably we are justified in giving a larger window of larger window using non-invasive ventilation. What are the conditions where we should not think of using a non-invasive ventilation? The patient is gasping, patient does not have a pulse, is not breathing, you are not happy with the respiration of the patient, you should never think of NIV, you should always go ahead with intubation. Patient is in shock, BP is less than 90, do not think of NIV. Patient is comatose, altered sensorium, GCS is low, do not think of NIV. Patient is vomiting, patient may aspirate, patient has secretions, all this situation is all these are contraindications for non-invasive ventilation, and you should tube these patients. Okay.
Just an interruption. Now you told why not mechanical ventilation, why go for NIV? Like that, can you just explain why not HFNC and why NIV? The other way also, just for the benefit of in this situation, for the benefit of the students, the viewers.
Yeah. So our patient had failed NRBM at 15 liters. So giving 50 liters of oxygen we were giving. Okay, so we were giving 50 liters of oxygen. Now, before going in for NRBM, another option that we have is going ahead with the high flow nasal cannula. So if we give a high flow nasal cannula, theoretically, if you use a high flow nasal cannula, you give FiO2s of around 40. You can give the oxygen flow is 40 to 60 liter per minute. With an NRBM, it's only 50 liter per minute. But with the HFNC, theoretically, we can give up to 40 to 60 liter per minute of oxygen, which will amount to an FiO2 of 100%. But still, you have to keep in mind that for that we need the normal flow meter that we use will not actually give, because we are only still setting only an FiO2 of 15. അതിന് നമ്മൾ കുറച്ചും കൂടെ മുകളിലേക്ക് ആക്കി വെച്ച് കഴിഞ്ഞാൽ മാത്രമേ നമുക്ക് അത്രയും ഒരു ഹയർ FiO2 കിട്ടത്തുള്ളൂ. So we are not actually giving so much oxygen with the അല്ലെങ്കിൽ നമ്മൾ കൂട്ടി വെക്കണം. But the advantage of HFNC is that HFNC will give you one thing that we need to understand is that in the respiratory system, there are two things. One is oxygenation, the other is ventilation. Oxygenation is about improving oxygen. Ventilation is about washing out carbon dioxide. Oxygenation primarily depends on two things. Oxygenation depends on FiO2 and your peak end expiratory pressure. These are the two things. Expiratory pressure, FiO2. ഇത് രണ്ട് കാര്യങ്ങളാണ്. So if you want to the oxygenation of this patient, you have to either increase your FiO2 or you have to increase your PEEP. The third thing that can improve oxygenation is positioning, prone positioning, changing positions, all these things, making the patient, sitting up the patient, all these things can have some improvement in the oxygenation of the patient. Inspiratory time improves, but that may not be very that significant. So primarily our modalities of improvement are FiO2 and PEEP. A HFNC can give a end expiratory pressure of up to 5 centimeters of water. So that is the advantage of HFNC. Will give you an FiO2 of 100 and a PEEP of 5. ഞാൻ കുറച്ചുകൂടെ explain ചെയ്യാം when I try to explain the difference between a BiPAP machine and a ventilator NIV. Okay. So now about masks. So that was about the patient. What type of patient should we take for non-invasive ventilation? The next thing is what type of mask should we use? The first one that we see is this is a nasal mask. His mouth is open. This is a full face mask. But then again, the air is high, so it is difficult for the patient. This is a helmet that we do not have. It's not available for us, so we are not commonly using it. So how do you learn to use non-invasive ventilation rightly? The most important thing in using non-invasive ventilation rightly is avoiding leaks. So that is the most important thing. So leaks are what causes most of our non-invasive ventilation to fail. So you have to really work on decreasing these leaks. How will we decrease leaks? So this is an orofacial mask. It covers the nose and it covers the mouth. So when what type of, there are three types of NIV oronasal masks that are available. We have all these three types available in our hospital. We have a small type of oronasal mask, a medium type, and a large type. So we have to carefully select which type do you want to use for this patient. So what should be, the oronasal, the top upper border of the oronasal mask should be at the bridge of the nose, and the lower border of the oronasal mask should be at the lower border of the lip. It should not be at the lower border of the chin. ചിന്നിന്റെ താഴെ വരുമ്പോഴുള്ള പ്രശ്നം എന്താ? ചിന്നിന്റെയും മാസ്കിന്റെ ഇടയിലൂടെ നല്ലോണം ലീക്ക് ഉണ്ടാവും. So that is one of the commonest causes of leak. So you have to use an appropriate size of mask, usually a medium sized mask, and you should make sure that the lower border of the mask is at the lower border of the chin. If the patient needs a large mask or a small mask, you should appropriately use that mask. You should look for leaks around. Keep your hand and see whether there are leaks on the sides of this mask. Is it going into his eyes? If the headgears are too tight, it will cause leak. If the headgears are too loose, it will cause leaks. If the headgear is more tight on one side, it will cause leak through the other side. So all these things are small things, but these are very important. Why is this important? Most of you are working in our wards. The most dreaded thing that we are afraid of now is an oxygen pressure drop. So now what is causing an oxygen pressure drop? So NRBM gives you 50 liter per minute of oxygen. Your mechanical ventilator usually uses only 50 liters per minute of oxygen. It does not use, it may use up to 20, maximum 20-25. It will not use the flow that comes out of a intubated mechanical ventilator is not much greater than 20-25 liter per minute. Usually it is 15 liter per minute. But when you have a leak with a ventilator NIV, you are using non-invasive ventilation with a mechanical ventilator and you have a leak, the flow, the peak flow can go as high as 120 liter per minute. In fact, we have seen going peak flows more than 150 liter per minute. So this much oxygen is actually leaking out. And when you have 5 or 6 NIVs, all these NIVs are actually leaking through their masks or other areas. There's a significant leak in the system that is happening, and this can cause pressure drops. So that is why leaks are very important. You have to actually troubleshoot the leak by taking time for every patient. Okay, so what type of mask should you use for this patient? Earlier, see now we can give ventilation with a BiPAP machine, a portable NIV or a mechanical ventilator. You can use a NIV. No, you can use NIV. You can give non-invasive ventilation through an adult critical care ventilator, and you can use it through the portable BiPAP machine. Earlier, we used to use a vented mask, a mask which has a hole for BiPAP machines and for an ICU ventilator because it has two limbs. I'll show you a diagram later. We used to use a non-vented mask. But now because of aerosols, we will use a non-vented mask. I'll show you the diagram later. So how do you reduce? The problem with NIV is that it will reduce aerosol generation. So this is a BiPAP machine. You have a BiPAP machine. It is a single limb circuit. You have a vent in the mask. Through the vent, all sorts of viruses are coming out in the circulation. There is a high. It is not recommended. There is a high risk of aerosolization with such an NIV. So how will we decrease NIV with that? What you have to do is you should not use a vented mask. You should, after the non-vented mask, you should use a viral filter. You should use a bacterial or bacterial viral filter, and after the bacterial viral filter, so for the carbon dioxide escape, we attach a leak port here. So the expired air coming out from the lungs of the patient travels through the viral filter, and then only it goes out through the leak port into the atmosphere. And you have to change the viral filter at least once in a day. So that's it. But so this will decrease aerosolization. But the least aerosolization we will get if we are using non-invasive ventilation. ventilation with an adult critical care ventilator. It has two limbs. One limb is for inspiration, the other limb is for expiration. And at the end of expiration, you should attach a viral filter so that the air that's coming out of the expiratory limb is a filtered air. So this is the most safest one. If you are using a BiPAP machine, make sure you are using a non-vented mask with a leak port filter attached in between. So this is a non-vented mask with a viral filter here and a leak port, a leak port or an exhalation port or a exhalation port that we use. So this is how you should use a for a BiPAP machine. What about leaks? Just show you one. Okay. So what about leaks? If you look, usually we have two types of machines. We have the Rasmed machine and the Philips machine. So all these machines, if you go into the monitoring page, it will show you how much leak is happening. It will show you whether the leak is 30 liters or whether it is 100 liters or 150 liters. So you can allow a leak of 30 liters. A leak of 30 liters is needed for most ventilators, and most machines will well compensate this 30 ml leak. Whereas a 40 whereas higher than 60 are very high, and you have to troubleshoot and find out what is causing the leak. So all these leaks will actually cause asynchrony. These leaks will cause asynchrony and all sorts of problems. So now, as we said, we can give non-invasive ventilation using a BiPAP machine and an adult critical care ventilator. So now, what are the difference when we use a BiPAP machine and an adult critical care ventilator? Now, when we use a BiPAP machine, the oxygen that we are connecting to this is only 15 liter per minute. And along with the 15 liter per minute, the machine will take in atmospheric air. So the more IPAP you use, the more pressure the machine, more air the machine will take in from the atmosphere, and your FiO2 will fall. So the maximum FiO2 that you can give with a BiPAP machine is only 50 to 60%. So that is the most advantage of using a BiPAP machine. It has only a single limb, so carbon dioxide rebreathing may be there. The advantage of a BiPAP machine is that it compensates leak well than most adult critical care ventilators. Okay, and the terminology that we use here is EPAP and IPAP, whereas here in a critical care ventilator, you use a PEEP. The names are slightly different. Whereas an adult critical care ventilator, it has an oxygen blender inside it, so it will give you 100% oxygen. Patient is not improving with, if your oxygenation of your patient is not improving with a BiPAP machine, it is because the FiO2 is not adequate. So what you should do is, try, if you are not planning to intubate the patient, shift the patient from a BiPAP machine to a ventilator NIV, so that it is your patient is getting an FiO2 of 100%. And the advantages are, you have an alarms and you have a double limb circuit. These are the other advantages of an adult critical care ventilator. Just one word about mode. There are different modes. The CPAP, but then CPAP just gives you a end expiratory pressure alone. It will not, നമ്മൾ ശ്വാസം എടുക്കുമ്പോൾ ശ്വാസം എടുക്കാൻ സഹായിക്കത്തില്ല. ഒരു എക്സ്പിറേറ്ററി പ്രഷർ മാത്രമേ തരത്തുള്ളൂ. ഇൻസ്പിറേറ്ററി പ്രഷറും കൂടെ കൊടുക്കുമ്പോൾ എന്താണ്, ഒരു പേഷ്യന്റ് ഒരു നെഗറ്റീവ് പ്രഷർ ജനറേറ്റ് ചെയ്യുമ്പോൾ മെഷീൻ ആ നെഗറ്റീവ് പ്രഷർ പേഷ്യന്റ് സഹായിച്ചു കൊടുക്കും ബ്രീത്ത് ചെയ്യാൻ വേണ്ടിയിട്ട്. അങ്ങനത്തെ ഒരു ഇൻസ്പിറേറ്ററി പോസിറ്റീവ് എയർവേ പ്രഷർ മോഡിൽ കിട്ടത്തില്ല. മോഡിനെ പറ്റിയിട്ട് ഇറ്റ്സ് കുറച്ച് കോംപ്ലിക്കേറ്റഡ് ആണ്. സോ ദ ഓൺലി തിങ് ദാറ്റ് യു നീഡ് ടു നോ അറ്റ് ദ ലെവൽ ഓഫ് എ നോൺ അക്കാഡമിക് JR is that keep the patient, keep the NIV on an ST mode. Keep the NIV on an ST mode. So every breath that you give, when you give every breath has 3 parts. This will be discussed in detail in the ventilatory class. You have a trigger, you have a limit, and you have a cycling. Cycling is when the breath moves from inspiration to expiration time. Okay, I'll just explain this graph and go ahead. So this is a graph. This is the pressure is in the y-axis, time is in the x-axis. You throughout the respiratory cycle, you are giving an expiratory positive airway pressure. സിസ്റ്റത്തിൽ എപ്പോഴും ഈ ഒരു എക്സ്പിറേറ്ററി പോസിറ്റീവ് എയർവേ പ്രഷർ ഉണ്ട്. ഇതാണ് ബേസ് ലൈൻ. ഈ ബേസ് ലൈനിന്റെ മുകളിൽ പേഷ്യന്റ് ബ്രീത്ത് ഇൻ ചെയ്യുമ്പോൾ the patient generates a negative pressure. You can see that the pressure is dropping. So the patient when takes in a spontaneous breath, there's a negative pressure generated. This creates a trigger, and when a trigger is created, the machine gives you the IPAP. The IPAP is the pressure support. That is the difference between the IPAP and the EPAP. The difference between the IPAP and the EPAP determines your tidal volume. Okay. So this is important to understand. For a BiPAP machine, the terminologies that we use, this is important because if there's a lot of confusions. So if you're using a portable NIV or a BiPAP machine, the terminologies that the expiratory pressure we give is called as an EPAP, and the inspiratory pressure that we give is called as a IPAP. IPAP 20, EPAP 10 എന്ന് പറഞ്ഞു കഴിഞ്ഞു കഴിഞ്ഞാൽ പ്രഷർ സപ്പോർട്ട് 10 ആണ്. ഓക്കെ ഓക്കെ പക്ഷേ ക്രിട്ടിക്കൽ ദ ടെർമിനോളജീസ് ദാറ്റ് വി യൂസ് ഇൻ ക്രിട്ടിക്കൽ കെയർ വെന്റിലേറ്റർ ഇസ് ഡിഫറെന്റ്. അവിടെ നമ്മൾ EPAP 10 കൊടുത്തിട്ട് പ്രഷർ സപ്പോർട്ട് 7 എന്നാ പറയും. അല്ല IPAP എന്ന് പറയുമ്പോൾ ഇത് രണ്ടും കൂടെ ചേർത്തിട്ട് പറയുന്ന സാധനമാണ്. To just understand that difference. Okay. Yeah, great. So how do you start NIV for a patient? It is always better to make the patient in a sitting position because your diaphragms are working better so that the patient is able to breathe better. So make the patient, the position is very important. You can see that if you adjust the position, you raise the end of the bed, you put in a backrest, you can see that box is improving. Make the patient sitting position. Explain this thing to the patient. You are going to pour in, like you pour water on your face, you are going to pour in air at pressure to the mouth, to the face of this patient. So explain the procedure to the patient. We are going to give in air. Ask the patient to try to synchronize his breath with the breath that the ventilator is giving. Machine let's allow the ventilator to breathe you. Tell them the gain is confidence. Tell them that we can stop when he is uncomfortable. Choose right size of mask. Decide on what is FiO2 that you want to give. We talked about the difference between the low FiO2 that can be delivered by a BiPAP machine and the high FiO2 delivered by a critical care ventilator. Look for leaks and adjust the traps. An ST mode can be selected. So how will you start NIV for a BiPAP machine? So if you are using a BiPAP machine, start at 15 liter per minute of oxygen, and because as we said, oxygenation depends on expiratory PEEP and a high FiO2. Start with the PEEP of 6 centimeters of water. So and try to increase your PEEP by 2 centimeters of water. Try to increase it up to 10 centimeters of water and see if you have attained adequate saturation levels or not. If your target saturation is only more than 92%, if your saturation is 93, you are happy with your PEEP and FiO2, and you are happy with the patient, you can send an ABG and look at the PF ratios and continue monitoring this. If even after, what if even after doing these things, the patient has an increased work of breathing, or in other words, the patient is tachypneic? Even after this, the patient has a respiratory rate of 40, or the patient's sternocleidomastoids are working. That means that his work of breathing is high. The patient will the patient will not be able to breathe at this high rate for long. His respiratory muscles will get fatigued. So in such a case, you have to give or an IPAP. So you start giving, even from the beginning, you can give an EPAP of 6 and an IPAP of 10. The gap should be minimum 4. So and then depending on the respiratory rate and the working of his sternocleidomastoid, you can slowly increase your pressure support. And so a conservative maximum EPAP that you can go to increase his oxygenation is 10, and a conservative high IPAP to relieve his work of breathing is 20. But then you can go in our situation, maybe you can go up to 15, EPAP up to 15 and IPAP up to 25 in, so that, but then you need to thoroughly monitor these patients. So now we have started the patient on NIV, we started this patient on high FiO2, and we started this patient on a, let's say, a PEEP of 10. And how will we monitor this patient? You are looking at the patient, we should try, ideally we should try to, when we are taking rounds, we should try to take his try to talk to the patient, if it is possible to remove his mask and talk to the patient, see if the patient is comfortable or not. Look at his respiratory rate. If his respiratory rate is very high, maybe his work of breathing is high. If axillary muscles are working, you may have to increase his IPAP. Look at the saturation. Is it falling? Do I have to increase FiO2 and PEEP? Is the patient's BP falling? If the BP is falling, maybe, and if there's a significant hypotension which is not improving with inotropes, maybe NIV may not be very suitable for this patient. Tachycardia, find out what is causing the tachycardia. Look at the mask daily. Is there a leak? What is the fit of the mask? Look at whether there is abdominal distension or not. What should you monitor in the NIV machine? This is the normal screen of our usual ResMed machine. So you can see that in the monitoring screen, you can monitor for the leak of the patient. So if leak here, the leak is only 7, but if the leak, that is fine. But if your leak is more than 60, then you have to troubleshoot whether the respiratory rate is high. You can the tidal wall. The tidal wall depends on the difference between IPAP and EPAP. So if your tidal wall, you have to try to get a tidal volume of 6 to 7 ml per kilogram, so that you're expecting a tidal volume of 360 to 420, something like that. So if your tidal volumes are low and that is not due to your leak, then maybe you can increase the difference between your IPAP and EPAP so that you have a better tidal volume. Yeah. Patient is struggling, try to give dexmedetomidine or haloperidol, know when to intubate. And how will you wean from an NIV? What you can do is try weaning off slowly from your NIV, try to give an intermittent NIV. Another thing that we can easily help our patients is by awake positioning, asking the patient for awake positioning. Ask the patient to lie down on his right with an NIV. Ask the patient to lie down on his right side for 2 hours. Ask the patient to lie down on his left for 2 hours. Ask the patient to sit up for 2 hours. Ask the patient to, if there's a good bystander, if we have attenders, ask the patient to lie prone for 2 hours. So, why is this important? Like, this was what Gattinoni and all showed. This is a CT scan. You can see that this is a CT scan immediately before and immediately after proning. So here you can see the heart here, spine here, all the opacities aspect. But then when we prone this patient,
slide change ചെയ്യുന്നില്ല. Vineeth, please check. CT scan is not
display കാണുന്നത് LCD NIV-ന്റെ LCD കാണുന്നത്.
ഇപ്പോഴും സാറേ
ഇല്ല മാറിയിട്ടില്ല.
ഇപ്പൊ കാണാവോ സാറേ? സ്ലൈഡ് കൂടെ ഉള്ളൂ. കാണുന്നില്ല?
ഇല്ല.
കാണുന്നില്ല സാറേ?
ഇല്ല വന്നിട്ടില്ല.
എനിക്ക് pneumomediation.
Now it has come.
ആ സ്ലൈഡ് തന്നെ അതന്നെ ആ ക്വസ്റ്റ്യൻ സ്ലൈഡ് അത് ഫുള്ളാക്കിയാൽ മതി.
ഓക്കെ ഞാൻ ഇങ്ങനെ പോട്ടെ, ഇനി ഫുള്ളാക്കി കഴിഞ്ഞാൽ പോകും.
മതി ഓക്കെ കുഴപ്പമില്ല, പോയ പ്രശ്നം.
ഇപ്പൊ കാണാമോ?
കാണാം.
ഓക്കെ ഫൈൻ. So again, immediately after proning patient, you can see that all the densities that are in the dorsal aspect has shifted to the ventral aspect. So that at this point, the areas that were not ventilated on supine position are getting ventilated. So theoretically, this advantage we will get even on a patient with NIV. So let us try to talk to our patient and try to ask them for frequent position changes like right side, left side, sitting, proning, and all these things. So how will we troubleshoot? So if our patient has a persistent hypoxia, change from our BiPAP machine to our NIV ventilator, increase your EPAP or your PEEP, look for positioning. The main reason why your patient is in hypoxia may be that you have a leak. So adjust the leak. That will actually, most commonly, what the last 1 week I was in COVID, we have very sick patients with NIV. So we have seen these leaks. Once you really troubleshoot the leak, the hypoxia actually improves. And if it's still not improving, go ahead and intubate the patient. How will you troubleshoot a hypocarbia? If you want to wash out the carbon dioxide, you have to increase ventilation. How will we increase minute ventilation? We will increase the tidal volume and respiratory rate. How will we increase tidal volume? By increasing the inspiratory pressure and respiratory rate. And troubleshooting the heat. These are some small things. Just leave that. So, but there's one thing. This is an X-ray that was taken by one of our patients for 3 days back. So the patient was on NIV. Patient was saying that there is some pain on his neck. When we looked at, there was a fullness in the neck. There was subcutaneous emphysema. We took an X-ray. The X-ray showed a subcutaneous emphysema. It showed a pneumothorax, and there was also a doubtful pneumomediastinum. So yeah, that's it. So we have trauma to our patients. So we had to put an ICD for this patient. So this is one thing that we have to keep in mind. And this was a slide from NEJM, and we can see that the transpulmonary pressure is highest in non-invasive ventilation. Here, even in the mechanical ventilation, we are giving only, for example, a patient who is well sedated on mechanical ventilator, we are giving the alveolar pressure generated is 9. There's no pressure coming from NIV. There is significant, if the patient is in distress also, he is producing large negative pressures. And along with this large negative pressure, we are also giving a good IPAP and EPAP. So the transpulmonary pressures are very high and go very high, and the patient can go in for barotrauma. So always, if the patient is desaturating, keep these things in mind. You always worry about whether the patient will go in for a barotrauma. Second last slide. What are the complications you are expecting? Choose the right mask, choose the right size, choose the right fit. The answer for all leaks is not to increase the headgear tension. There was one patient who died who was saying when he was communicating to his family members that the only thing that doctors do is they come and tighten my headgear and go away. So maybe the thing that has to be really done is to loosen the headgear, and then it will actually decrease the leak. That's what at least theoretically the textbooks say, and I think that's right. So look over the nasal bridge. If your headgears are very tight, patients have get pressure. We currently have a patient who has a pressure sore on the nasal bridge. Look into that. If there are pressure sores, keep at least a gauze or something like that there and try to do these things. We are giving high flows to these patients, and normally our sinuses and mucosa will humidify and heat these air. But when we are not using a humidifier and heater, it can cause lot of congestion and dryness to these patients. So use a HME. Erasmus has a humidifier, fill the water in it. Do these things. If there's gastric distension, maybe if there is significant gastric tension, maybe you can consider putting a ice tube. Always, if a patient is in risk of aspiration, do not keep on NIV. Yeah, hypotension may be due to high peak pressures. These are some complications. So I think now you have some idea about how you will do. You try to change the mode to ST mode. If only problem is oxygenation, increase CPAP, and if the patient still had tachypnea and using stensiloid methods, increases IPAP. So these are the things that you will do. And the $1,000,000 question, which I did not address, is when should I intubate this patient? Should I intubate this patient or not? Or should I continue giving high NIV to this patient? Now, there is no, it's very difficult to give an answer to this question. And probably there are no trials which will give you an answer. So there is no strong evidence by which we can say that no strong evidence to back us. So then the only thing that you can do is you can look at the patient as a whole, look at his saturation, how much FiO2 am I giving, and with this FiO2, what is the saturation the patient is developing. If the patient is becoming altered and all, then maybe that is a strong case for that. If the patient is becoming too tachypneic, becoming his tidal volumes are falling, if the work of breathing is becoming very high, then definitely go ahead and intubate the patient. So that is it. I think I rushed through non-invasive ventilation. We have 2 more topics coming up on mechanical ventilation. This was during the polio epidemic, and maybe you can see what all things they try to do during that epidemic. Maybe we will also, after some many years, we will also look back and say that these were difficult times, and we also try to do some things to help our patients. Okay, thank you. If there are any questions, we can take that.
Hello, sir. Hello.
Vineeth, you showed the last slide, no? Can you just explain to the students what are those are negative pressure ventilators or tank ventilators which we are not using now? A slide of the just to explain what is the difference between that negative pressure? What is it?
So now what we use is a positive pressure ventilation. We give even in a mechanical ventilator or in a non-invasive ventilation, what we do is we give a positive pressure into the lungs of the patient. ആദ്യം വെന്റിലേറ്റേഴ്സ് ഇരുന്നില്ല. ആദ്യം വെന്റിലേറ്റർ കണ്ടുപിടിച്ചപ്പോൾ പേഷ്യൻസിന് ഒരു വലിയൊരു ടാങ്കിനകത്ത് ഇടുക ചെയ്യുക. ഇതേപോലെ യു ക്യാൻ സീ ദ ടാങ്ക് അല്ലേ. സോ യു വിൽ പുട്ട് ദ പേഷ്യന്റ് ഇൻ എ ടാങ്ക് ആൻഡ് ദെൻ യു വിൽ ജനറേറ്റ് എ നെഗറ്റീവ് പ്രഷർ ഇൻസൈഡ് ദ ടാങ്ക്. സോ ദിസ് നെഗറ്റീവ് പ്രഷർ വിൽ ആക്ച്വലി കോസ് എ നെഗറ്റീവ് intrathoracid pressure and will help the patient to breathe. So this is the type of, so imagine how difficult and how cumbersome it would have been at that point. But then they found that after this, the positive pressure ventilation was invented, and yeah, that's it.
I will just like to add one thing. This is though it is cumbersome and difficult, this is more physiological because the negative intrathoracic pressure generated in the tank sucks in the air into the lungs, which is similar to the normal respiration. But the problem is when the patient has to be put inside the tank, the nursing is difficult, the intravenous drugs are difficult, all those things. So later we changed. Now we don't use this type of ventilators and we changed to positive pressure ventilation. The positive pressure ventilation is basically unphysiological. Instead of use the negative pressure sucking in the air, atmospheric air into the lungs during the normal respiration, we are forcibly or pumping in air into the lungs by positive pressure. So it is exactly opposite to what is being like. Instead of going in a forward gear by the way you suddenly change to a reverse gear, what will happen? So that is something happening in a mechanical ventilation. So that itself is unphysiological, but we are so that will create all sorts of unphysiological things, that the hypotension, cardiac arrest occurring and all. But the current ventilators, but due to the practical difficulties and the problems in nursing and unconscious patients, the airway is not protected. and all those things. It is not used, but the current mechanical ventilators are all, even the NIV, we are giving positive pressure to the patient. So we are pumping in oxygen or air to the patient to produce the lung expansion, which has problem of affecting the venous return and cardiac output and all those things. So since Vineeth showed those tank ventilators, I thought that is the difference. Maybe the other speakers may be telling about those things. Thank you, Vineeth. It was very good that you can clarify any students or participants' questions or queries. It was very, very good, very nice presentation.
Hello, sir. Sir, one
Okay.
question. Sir, in critical care ventilators, the leaks are usually shown in the percentages, not in liters. Hello?
Critical care ventilator.
Critical care ventilators, the leaks are usually shown in percentages, not in liters. So how much percentage are compensated?
ടൈഡൽ നമ്മളിപ്പോൾ യൂഷ്വലി ടൈഡൽ വോളിയം നമ്മളൊരു ടൈഡൽ വോളിയം 420 ആയിട്ട് എടുക്കുകയാണെങ്കിൽ അതിന്റെ പ്യൂരിറ്റൻ ബെനറ്റ് അല്ലേ ലീക്ക് പെർസെന്റേജിൽ കാണിക്കുന്നത്. ഐ തിങ്ക് ഇറ്റ് ഇസ് എ പ്യൂരിറ്റൻ ബെനറ്റ് ദാറ്റ് ഷോസ് ദ ലീക്ക് ഇൻ പെർസെന്റേജ്. അപ്പോൾ 420 നമുക്ക് ഇഫ് യു ആർ ഹാവിംഗ് എ ലീക്ക് ഓഫ് 60%, then that would mean that you have a significant leak. So that would എനിക്ക് എക്സാക്ട്ലി അറിയത്തില്ല, പക്ഷെ ഐ തിങ്ക് മോർ ദാൻ 20 ആണെന്ന് തോന്നുന്നു. ഐ എം നോട്ട് വെരി ഷുവർ അബൌട്ട് ദാറ്റ്. ഐ ഹാവ് ടു ചെക്ക് ദാറ്റ്. I think 10 to 20% ആണെന്ന് തോന്നുന്നു. ഐ എം നോട്ട് ഷുവർ അബൌട്ട് ദാറ്റ്. There are no more questions, then we can go into, because we have 2 more sessions coming up. If there are no more questions, we can go into the next session. Chat questions illalo. Okay. Over to Neeraj sir for the next session on basics of mechanical ventilation. Thank you.
Thank you, Vineeth. It was a really wonderful talk, and thank you for the enlightenment messages given by Mubarak sir too. Am I audible, Vineeth?
You're audible. You're audible.
Okay. Thank you.
Audible.
Thank you, Mubarak sir. So Vineeth has slightly told that what are the disadvantages of non-invasive ventilation. So also yes, Mubarak sir has told the unphysiologicalness of the mechanical ventilation. My slide visible?
Not yet.
Not yet. Wait some more time. So the basic problem, as you have been told, is that you have seen the iron lung. Iron lung were in the people in the polio epidemic of Boston and US. They were being put in that iron lung where it was people were made to do the negative pressure ventilation. But remember, it was very cumbersome. As Mubarak sir rightly told that there was difficult treatment for the patient, to start an IV antibiotic for the patient, to meet the day-to-day urinary and fecal needs. Lot of trouble were there, and it is at that point of time somewhere the invasive mechanical ventilation came into practice. It had its own goods, but the demerits were much larger actually.
Yes, it was coming.
Okay.
Slide show there.
Okay.
Okay.
Full state.
Okay. So the next half an hour or so, I'll be detailing on the very basics of mechanical ventilation coefficient. As Vineeth rightly pointed out, mechanical ventilation is unphysiological, but at times of dire straits, like where non-invasive ventilation fails and you have a patient with a good quality of life, where you see that switching from a conventional NIV ventilator to a mechanical ventilator based NIV ventilation still fails at times due to the severity of the illness, then we are at dire straits. At that time, we'll be obliged to go for a mechanical ventilation. Especially in COVID, we have had really bad results with mechanical ventilation. The two things that are important in mechanical ventilation in a COVID patient is the timing of when you should start a mechanical ventilation, which is the most important thing that I think is where when we decide on very late in starting mechanical ventilation, we have a lot of failures and a lot of deaths. So coming to my topic, there are no conflict of interest. The talk objective is to discuss the basic rationale of positive or patients with ARDS secondary to COVID-19 and nothing else, and review the basics of volume control ventilation, which is a basic mode of ventilation that we use in basic mode of mechanical ventilation that we use in COVID-19. It's just like getting a new mobile which has so many features and you are just learning how to just dial a number and get a person. So that's the basic thing that we have to learn before we go for advanced learning. We just want to know how to phone a friend, and then that phone that friend may help. Now, I will try to explain how to set up and adjust the important parameters in a basic volume controlled ventilation in a COVID-19 patients. So it's limited to COVID-19, it's limited to COVID-19 with ARDS, and it's limited to basic starting of ventilation in a COVID-19. Now, basically, you can see different supportive devices in this figure. On the top left, you have a hemodialysis patient on a dialysis machine. On the right, you have a patient on a MORS for a liver failure patient. On the down left, who is on a ventricular assist device awaiting his heart transplantation. On the down right, you have a patient who is on a ventilator on an ICU with multi-parameters. Now, basically, what does all these do? These just support your organs in terms of crisis, in this context, COVID-19, and will help you tide over the crisis. Remember, none of these machines reverse the illness. None of these machines treat the illness. It is just buying time till the natural history of the illness or the treatment you are being received for that illness make you better. So end organ supportive devices does not cure illness, are not miracles. They just help you tide over the crisis. You have respiratory failure, you ventilator, tide over the crisis till your organ, the lungs take up the original function it has been doing for years. In CKD patient, your hemodialysis machines take over your function of your kidneys till you get a new renal transplant. So they are just temporary measures and don't expect much more than that from them. These two children, you have exactly two children, one happy child who is eating by his own in the upper left corner, and you can see the child on the down figure is not at all happy because his mother, his grandmother is asking him to take food. See, eat the carrot, it's good. Eat the beetroot, it is good for your health. Eat this, that. So the child is not happy, while the child in the upper figure is very happy. It's like this when you do an NIV and a non-NIV. NIV is more physiological. You are helping the patient to breathe. He's having his own freedom compared to a mechanical ventilation or invasive ventilation where you are putting pressures on the patient. And the patient is never happy. Nobody is happy at that point. Your body is not happy, your physiology is not happy, your psyche is not happy, you are not happy. So this is the basic difference between an NIV and an invasive ventilation. Because as Neeraj rightly told, normal physiological breathing, which we do it 14 to 16 times per day, day in and day out, even when we sleep, is a negative pressure ventilation. Your body sense your pontine center sends signals for the diaphragm to contract. It contracts. It pulls the lung and the pleura along with that down, and that creates a negative pressure inside the pleura. That translates to a negative pressure inside the lung, and naturally, as physiology goes, air flows from a high pressure system to a low pressure system. So when you breathe in, your diaphragm contracts, your lung expands, and the pressure inside the lung drops. So the pressure that is outside, which is higher, flows into the lungs. It's the normal physiology. This is in a normal respiration. This is what happens as well in a non-invasive respiration, a ventilation. But when it comes to invasive, this is taken topsy-turvy. What happens in invasive ventilation is that your machine creates a positive pressure and blows that into your nose or airway and into your lung. And you are made to relax your diaphragm, contract your diaphragm, and accept that whatever is given. Now the problem comes that when your body is not ready to accept what is being between your lung, body, and the machine, and that's a sole purpose. That's a sole problem of a mechanical ventilation or invasive ventilation. We come to that detail. Now these are the things that the different types of NIV that come similarly to the different types of versions of mobile that we get. Basically, they have two things: what we ask them to deliver and what they deliver actually. So these are the two basic parameters that has to be addressed in a mechanical ventilation. We ask, these are the parameters you have to deliver in a mechanical ventilation, and we see percentage of these or what extent of these are being delivered. Now coming to COVID ARDS, COVID ARDS we know has definitions. Vineeth has rightly told is an acute respiratory illness with a bilateral opacities and a PO2 FiO2 ratio of less than 300 at room air. And that cannot be explained by a cardiac failure or other illness. So basically it's fluid in the lungs, fluid and inflammatory markers in the lung, which are produced by a COVID pneumonia and not due to heart failure or a primary myocardial disease. Now why do you want to choose ventilator as ARDS? Because Vineeth has rightly pointed, compared to a standby NIV, the machine NIV or the invasive, the mechanical ventilator NIV has got a higher percentage of FiO2 delivery, which is a sole one of the parameters that can be used to assess to improve the oxygenation. So as Vineeth has told that COVID ARDS is a type 1 respiratory failure predominantly. So oxygenation is what is defective there, and improvement of oxygenation is what improves that. So the improvement of oxygenation, as he has rightly told, is by improving the FiO2. So here you can, when you use a ventilator support, you can increase FiO2 up to the tune of 100%. Next, as he told, is increasing pressure. So positive pressure will reduce the work of breathing and makes the patient easier. Imagine you are taking 40 breaths per minute. It might be okay for 1 minute. After 2 to 3 minutes, you feel you are not feeling well. After 5 minutes, you are definitely going to feel bad, because increased work of breathing means you have to increase your respiratory movement that persists over time. Definitely, there is something that you feel fatigued, and once you feel fatigued, especially when you are having COVID-19, you tend to give it. Just like you start giving away. So when positive pressure ventilation is there, the giving away feeling is not there, because that may be assisting your breath, assisting your effort of respiration. And at the end, it can give PEEP. PEEP is what would improve oxygenation next to FiO2. You can increase FiO2 to a certain extent, but after 100% you can't increase FiO2. And then what next is the amount of time the air in the lung is in contact with the epithelium and the blood. The more that amount of time, the more that the oxygen transfer occurs. So the more amount of oxygenation you can achieve. So that's what you can achieve by a mechanical ventilation. As I told earlier, spontaneous ventilation is a passive process, is an active process where the diaphragm contracts, followed by positive pressure ventilation is a passive process. There is nothing contracting. You are pushing in air and the diaphragm is being passively relaxed. So it's unphysiological. But at times of real danger, we have to opt for that. Now coming to what is a respiration. A respiration, normal respiration, we take it for granted. We take our breath, breathe out, and the rate and the frequency and the depth are influenced by various things. We know that when we stand for an exam in the Viva, we used to take deep sighs for reasons unknown. Run for a mile or so, we used to increase our respiratory rate by increasing the rate of respiration. So these are the variables that are various variables of a respiratory respiration that are determined by neurological causes and psychological causes. Now, when it comes to mechanical ventilation, these are things that are determined by the patient. So basically, there's a trigger. What makes me initiate a respiration? That's the trigger. There's a target. How much I should inspire before I should stop inspiration? And there's a cycle. At the end of inspiration, whatever has been decided, I will start to exhale. Baseline pressure from which I can again start from the inspiration trigger. So this
Neeraj is doing it in mobile. Mobile call on. Hello.
ഞാൻ ഒന്ന് വിളിച്ചു നോക്കാം സാർ.
നീരജ് മൊബൈലിലായിരിക്കും ചെയ്യുന്നുണ്ടാവും. കോൾ വന്നതാണ്.
ആ സാർ, ഞാൻ സാർ നീരജ് സാറിനെ വിളിച്ചിട്ടുണ്ടായിരുന്നു. സാറിന് കോൾ വന്നതാ, റീകണക്ട് ചെയ്തോണ്ടിരിക്കുക.
Slide visible ആണോ Vineeth?
Yes, visible.
So this is what a ventilator display would look like. Here are certain parameters down here which are being set by us, and there are certain parameters in the x-axis which are being actually delivered. There might be mismatch between what we ask, what is actually being delivered, because the patient is there as an interface and patient can change the parameters. So also different other factors. So it's a prompt, we should be prompt enough to monitor what are being asked to be delivered and what is exactly being delivered. So this would be a checkpoint in what the patient would be achieving. Okay. Now coming to the modes of ventilation, basically I told that this is like a juggernaut. Maze. So basically it's something that you can trigger between a trigger target, and to come to that you have a lot of modes of ventilation. But basically remember that we are trying to learn to telephone using the new mobile phone. So all we want is a PCV mode or a controlled mode ventilation. There are other modes of ventilation, we can always learn on that. So we'll stick to this for this class. So trigger is what initiate a breath. So who should initiate a breath would be determined by what we set on the mechanical ventilation. Suppose a patient is unconscious, drowsy, or stuporous, or you can decide that you decide the patient how much breath the patient should have. You suppose the patient is an individual who is breathing, you can always see his respiratory rate and set on that rate. So who initiate breath would be either ventilator initiate breath or the patient initiate the breath. Next would be who triggers it. Triggering is something like control. So if you trigger something, that means next to triggering, whatever you do is ineffective. It will be controlled by the machine actually. So when you initiate that, for example, I would say that I set up a patient on a ventilator to receive 14 breaths per minute. The machine determines that for the next 1 minute, I will deliver 14 breaths for this patient at a predetermined frequency and predetermined volume. The patient triggered is what is called an assist. So when the patient, for example, I will set it at 14 per minute for a patient who is having some problem with ventilation, and the patient decides that he takes a 16th breath or a 17th breath per minute. So the next 16 and 17 breath would only be assisted. That means when what is set, it would assist the patient in taking the breath. I will come to that detail. And then there are various combinations of this, like assist, trigger, assist, control, which means that there are various components that are assisted. Basically, when you say that a controlled breath is being given, it means that you are extremely tired. You want to take a pull up on a bar. You can just hang on the bar. You have no energy to take the pull up, but the ventilator gives you the number of pull up you want. For example, this boy is hanging on a pull up bar. എക്സസൈസ് ചെയ്യാൻ പനിക്കുക, അയാൾക്ക് ഒരു 12 പുള്ളപ്പ് എടുക്കണമെന്നുണ്ട്. ആ പുള്ളപ്പ് എടുക്കണമെങ്കിൽ അയാളുടെ ആരോഗ്യം അയാൾക്ക് പറ്റില്ല. പിന്നെ എന്ത് ചെയ്യാൻ പറ്റും? അയാൾക്ക് ആ വെന്റിലേറ്ററിനെ ട്രിഗർ ചെയ്യാം. വെന്റിലേറ്ററിന് 12 പുള്ളപ്പ് എടുക്കണം. ഫോർ എക്സാമ്പിൾ 12 പുറത്ത് എടുക്കണം എന്ന് പറഞ്ഞാൽ, however fatigued he is, the ventilator determines and makes sure that he delivers that 12 breath per minute. This has to be compared with a assisted breath, wherein ക്ഷീണമുണ്ട്, പനി വന്ന് ക്ഷീണിച്ചിരിക്കുകയാണ്, 12 ബ്രത്ത് എടുക്കണം എന്നൊക്കെ ഉണ്ട് എനിക്ക്, പക്ഷെ ഫുള്ള് ചെയ്യാൻ പറ്റുമോ എന്ന് അറിയില്ല, കുറച്ച് ഞാൻ ചെയ്യാം. So some effort is being, he doesn't have the energy to take up the full entire work of breathing. So he triggers a breath. Once the breath is triggered, the ventilator would take over the breath. Now coming to the support breath, wherein he triggers the breath and he does some of the work. But then what he did is that he starts doing the work, he triggers the work and start doing the work, and that is supported by the ventilator. So these are the different degrees of dependency on breath, and that makes the patient more comfortable actually. We'll come to that later. So how much is assist and how much is control? Assist in the control in the 100% machine. Assist in the patient trigger, machine help you. Suppose a patient has a controlled respiratory rate of 10 breaths per minute. That means that every minute he takes takes a breath every 6 seconds. 60 seconds breath. Every 6 seconds he will take a breath. Now his intrinsic neural respiratory rate due to GOVT or some other illness is 20, which means that he will take 60 by 20, which means breaths every 3 seconds. Now what happened when this patient on assist mode ventilation? He will have 100% assistance for this breathing because number rate 10. So he's taking more than that. So whatever he's taking will be assisted, but rest he will be controlled. Now coming to the next part of this. Sorry. So much assistance, how much control when you have a patient has a respiratory rate of 30 per minute. For example, if patient is fairly common, so you'll be taking a breath every 2 seconds, and his neural respiratory rate will be 20. Now, what percentage of breath will be assisted and what percentage will be controlled? 100% will be controlled because the neural respiratory rate is much less than the set rate of the patient. When the neural respiratory rate is less than the set controlled respiratory rate of the patient in a ventilator, the ventilator just sees that if he takes anything less than 30, he will be delivered 30 breaths. So 100% this patient will be in control. What are the implications of this? Now coming to the ARDS protocol, what happens in COVID pneumonia is mostly ARDS. 90% of them it is in ARDS. Now the basic, as Vineeth has rightly told, that in ARDS we have two concerns. One is the oxygenation, the improvement of oxygenation. Now improvement of oxygenation, as Vineeth has rightly told, is by increasing the FiO2 and increasing the PE. Now there are certain concerns that happen in ARDS when you increase the PEEP in ARDS. The basic thing in invasive ventilation is that, as Mubarak has rightly told, that it is unphysiological and that is associated with hypotension and other change in body parameters. Now this can be deleterious because this patient is already having a severe pneumonia or a severe ARDS and his physiology is a challenge. Now, so oxygenation is the primary concern when a patient is on a mechanical ventilator for ARDS. At the same time, not producing unphysiological consequences. The thing that we will be looking is how safely we can bring down this patient to a baseline level. It's just like bringing down a plane who has lost his pilot to a safe landing. No, that's what exactly happens. We have a patient with ARDS with 40 and we have said
Neeraj again call on
the ventilator as a primary setting. Now basically I would place him on a volume control ventilation because that's the basic mode of ventilation that we can be comfortable with, and set him at a respiratory rate of 20 breaths per minute or one thing before he was intubated. Maybe in ARDS he might be breathing 30, 40, 50, 60. I would set him on the same rate except when it is beyond 40. Beyond 40 it doesn't have physiological advantage. So 36, a patient on crash ventilation is also on 36 before he crashed. I would intubate the patient and set him on that same 36 respiratory rate. Next, what I would do, I would set the tidal volume for the patient. The tidal volume would be something like 6 ml per kg for that patient, because we know that higher volume ARDS ventilation associated with lot of volume trauma and barotrauma to the lungs. So to prevent that, low tidal volume is accepted as a 6 ml per kg. And how much you would weigh the patient? No, for that we will use the ideal body weight, because in a crashed ARDS patient we can't weigh the patient on a weighing machine. So we would look for the ideal weight. There are a lot of formulas that would give you the ideal body weight. So for example, if he has a 50 kg patient, by the ideal body weight calculation, we would put him on a 300 ml tidal volume per breath. Next thing, because he has crashed or he is in the verge of crashing, I don't want to put him on a 100% FiO2, because I want his oxygenation improved at the best in the initial few minutes of ventilation. So 100 FiO2 is okay. Then I will set a PEEP at 15 centimeters of water. Now remember, the most important constraint in setting up a PEEP in a crash patient or an ARDS patient is the blood pressure. Most of the time they have lower blood pressures, and the moment we set up a PEEP, the blood pressure would drop down further and hamper the circulation and oxygenation. So it's a trade-off balance between the available BP, how much BP can do. Your aim should be the maximum tolerated BP, because that is what would translate to better oxygenation, better FiO2, better SpO2. And then I would check for the plateau pressure. Once the patient is on ventilator, the two things that would hinder the ventilation would be high plateau pressure, which would make the patient restless, distressed. So the next thing would be to look for the plateau pressure. And then if the blood pressure is high, I would decrease the tidal volume some more. And if still the plateau pressure doesn't fall, he has to be evaluated likewise. And once the patient is intubated and is on ventilator, the next best thing is to have a full sleep for that patient. He should have analgesia, he should have sedative, because you have a crash patient who is struggling for his birth. You put in a tube. A tube is something that is a foreign body. It is painful for the patient. Anybody has an endotracheal tube or any other invasive procedure, ensure that there is adequate anesthesia. The patient may not complain to you because you have put in a tube across his glottis and he can no longer communicate to you other than show restlessness. So remember, analgesia is one of the most important things you should ensure. Nobody asks for analgesia when the patient is on ET, because he can't express himself. So ensure that adequate analgesia is got for your patient. Next, adequate anxiety control, because anybody having an endotracheal tube across his glottis is going to have intense anxiety. Now, unfortunately, to say that these two things are the least addressed in most of our ICUs. We give the patient, we improve his oxygenation, but we tend to forget that he's a human being who has pain, who has anxiety, especially when a large endotracheal tube is there in his throat, and he's at the mercy of the ventilator and the doctor to get respiration. And once you have sedated and given pain relief to the patient, next thing is to ensure that whatever you have been done is doing good for the patient. That is by looking at the SpO2, and more refinedly by looking at a repeat AG. So what we would do is we look at a repeat ABG for the patient after half an hour to 1 hour, and then we start tuning the ventilator to assess the patient's deficits. As I told earlier, ventilator sedation is the most important thing. Ventilator analgesia is equally important. Once you have a patient on ventilator, next thing is to ensure that he is comfortable with that. And the agents what we use for sedation are midazolam, diazepam, lorazepam, ketamine. Remember, sedation doesn't ensure analgesia. They are two different things and two different pathways. So you can't achieve analgesia by giving sedation, and you can't achieve. They should go hand in hand. And then there are very effective ways of communicating with the patient on ventilator. It's both NIV and invasive ventilation. You can always ask them how they feel. They can communicate with you by verbal and non-verbal ways. They can communicate you with graphics or by writing something. It's very, very, very challenging, but very, very good to communicate with the patient. So to conclude my talk, a man without principles and will is like a ship without a compass. I think similar to analogy like putting a patient on a mechanical ventilation and not doing an ABC. You might have set your parameters, but you don't know what your parameters are attained to the patient. You might have said it to the patient, you might have given analysis to the patient. We don't know what physiological change you have produced, whether you are doing good to the patient or not doing enough good to the patient. So managing a ventilated patient is ABC is a must, and a regular ABC is what would make you tune the ventilator for a proper aspect. So now I think with this half an hour session we have finished something like a Zoom swimming lesson, and that would be something like learning hands-on experience. Like a child, somebody who is into a new job, into a new activity, the best thing to learn is by putting your hands on the job and learning from your colleagues. So all the best. Thank you. Any questions on this aspect? I'll be happy to answer.
Neeraj, I shall add a few things to this thing. It was a good thing for the beginners. Beginners, you have done well. One thing, don't think that all intubations are crash intubations. Try to
Yes,
avoid crash intubation and anticipate the patient who is likely to get intubated and plan in well so that the problems related to intubation will be less. So how do you put your a patient is on NIV or other modes of ventilation, and if the patient is going tachypneic, restlessness, all those things that Vineeth was showing the pictures and all, so you should anticipate. So in such patients, try to prevent dehydration. First thing, you should anticipate a hypotension and crashing post intubation. So try to ensure hydration by looking at the blood pressure, urine output, all those things, and drugs and equipments ready, and try and don't allow the patient to decompensate too much and go for a sudden intubation. So in that case, if you plan an intubation, try to maintain the hemodynamics. Try to give a small sedative, low dose of sedatives, because if you're anticipating intubation, you give a high dose of sedatives, the patient will go for hypoventilation and will land up in crash. So a small dose of anxiolytics, probably a low dose around 0.5 milligram or maximum. So there may be controversies. Some people may tell that will further depress. So depending upon your clinical judgment and your ability to intubate, you can give a smaller dose, those things, and try to do an anticipated intubation with us. In case you think the patient is anyhow going to crash, don't go to the mid of the night to crash intubation. So better before with senior help, or in daytime, or not going to the middle of the night. You try to do an elective intubation and try to save the patient and be settled before going to midnight, or your duty change over time. So that is one thing. So
Thank you, sir. Thank you, sir. Exactly as Sir has told, that's the most important thing. We should time before crashing. The patient should not be crashing in front of. We should anticipate this patient is a potential crashing patient, and intubate. Sir has told, when the right hands are there, try to get their help, because that would be something good for the patient and the long term. Any questions? I think since we are running late into the night, I think one more session is there. Arjun, സാറേ അടുത്ത സെഷനിലേക്ക് പോകാൻ സാറേ.
Can I start the next session?
Yeah, Arjun, you can start the session.
Okay. Audible? Hello.
Yes, 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 you're audible. Your audible slides are
Sir.
visible.
Okay, okay. So good evening, everyone. Today I am presenting mechanical ventilation monitoring and troubleshooting. Again, it's a very vast topic. I try to be concise as much as possible. So once we see a patient and we have intubated the patient and connected the patient to a ventilator, only our job is only less than half done. The most important thing that we have to consider here is how to monitor the patient while on mechanical ventilation, and also we have to assess the patient ventilator interaction. So monitoring means not only the vitals that we have to monitor, but we have to also monitor the ventilator graphics, which is also very important to assess the pulmonary mechanics as well as the patient ventilator interaction. So obviously, for monitoring purpose, the most important thing is we can measure the vital signs by connecting a multi-parameter, connecting the pulse oximeter probe as well as the ECG leads. The basic vital signs like heart rate, blood pressure, respiratory rate, oxygen saturation, etc. can be measured. So I'm not going to detail regarding the condition that can affect the heart rate. Only thing I will mention here is sometimes what happens, which we commonly see, especially those who have intubated the patients can see, is that following intubation, sometimes, especially if the patient is not properly sedated and paralyzed, the patient can go on to bradycardia, to have vasovagal stimulation during endotracheal intubation that we have to keep in mind. Another thing that we have to consider is the sudden fall in blood pressure. As Neeraj sir has previously said that while assessing the or while setting up the PEEP and all, especially if the BP is borderline, there's an increased chance that the patient may go on to hypertension, because normally what we are breathing is the negative pressure breathing, where during inspiration the pressure in the intrathoracic cavity becomes negative and the venous return in but what happens during a positive pressure ventilation means the venous return reduces, and if the BP is borderline, the patient can go on to sudden hypotension. So it's better to assess the volume status of the patient. Preferably, the IVC can be measured prior to intubation. IVC collapsibility index can also be calculated depending upon the expertise that is available to prevent development of hypotension. Now, coming towards the most important aspect is assessment of ventilatory status. Again, we have to keep in mind that ventilators mean a normal oxygen saturation. Oftentimes, what we are seeing is that when we ask the junior residents about what is the current status of the patient, they will say patient is okay, patient is having a normal oxygen saturation. But a patient, even with a normal or 100% SpO2, may be having a poor ventilatory function. So, the level of carbon dioxide measurement is very essential. So, ABG measurement is very important for assessing the ventilatory status of the patient. From ABG, we can also calculate the two bicarb multiple values can be obtained. So I'm not going to details regarding that. These are the normal PaCO2, PO2, pH values. The most important two important parameters that we have always monitor is the PF ratio as well as the alveolar arterial oxygen gradient. PF ratio, we can differentiate ARDS, or can classify ARDS into acute, sorry, in the case of ARDS into mild, moderate, and severe, depending upon the PF ratio. Also, it is essential to calculate the alveolar arterial oxygen gradient also. That is, it is obtained by the equation PaO2. This alveolar oxygen can be obtained by the equation Pb minus PH2O into FiO2 minus PaCO2 by R, where Pb represents the, and PH2O is the water vapor pressure that is equivalent to 47. PV is atmospheric pressure that is 760 and R is 0.8. By calculating the alveolar arterial oxygen gradient, we can assess the shunt status of the patient. So normally in case of a normal individual, the alveolar arterial oxygen gradient ranges from around 10 to 15. So a widening of alveolar arterial oxygen gradient means the patient has increased amount of shunting that is occurring. So daily we have to monitor the PF ratio. Whenever ABG is being taken, we have to measure the PF ratio as well as the alveolar arterial oxygen gradient to assess the response or the progress of the patient. Again, there is clinical application for pulse oximetry. The one it is used for continuous monitoring of the oxygen saturation of the patient. Also, we can titrate FiO2. That is, we can plan weaning and all based on the FiO2 value. And also, saturation should be also being recorded at the time when ABG is being taken. It's important to verify the ABG accuracy so that we can rule out venous sample. And the various factors that affect the accuracy of pulse oximetry, like especially in a patient who is hypovolemic or severe perfusion defect, or a patient who is having a saturation below 70, the accuracy of pulse oximetry drastically changes. Especially in also in females, make sure that you are applying the pulse oximeter probe in fingers without nail polish. Okay. Then again, temperature sensor vital sign I just mentioned. Now the important thing that the chest examination. Okay, examination of the chest is very important because as we are in COVID ICU and all, we are wearing the PPE kit, so it's very difficult to hear the lungs. Often difficulty in auscultation is there. So a proper examination just by examining using your hands, that is used for examination of a normal patient with respiratory complaints, we can examine the patient to assess the chest movement. This is very important because one is following intubation, sometimes the ET2 can migrate down to right mainstem bronchus that will lead to a single right mainstem intubation can cause left lung collapse, which can be identified by decreased air chest lifting on left side. Also, recently, I think last week also there were multiple, 2 or 3 patients who developed pneumothorax. Yesterday also one patient in COVID ICU I think had developed right-sided pneumothorax with pneumomediastinum and all. So, examination of chest is important. Look for surgical emphysema if patient is deteriorating and there is an increase in peak inspiratory pressure and all. We have to check for presence of tension pneumothorax in this patient. Then if for completion's sake, if auscultation, if we are able to auscultate the patient, well and good, we can look at the quality and characteristics of breath sound, absent breath sound, normal breath sound or added sounds. Also, another important thing that we can look for is cough leakage. So if there is a suspecting a cough leak, if the expiratory tidal volume is on lower side compared to inspiratory tidal volume, we auscultate over the level of trachea. And if over the level of trachea, if the patient is having an sound that is produced during inspiratory phase, it means there is some degree of cough leakage. So these are the various conditions that can produce various different types of breath sounds. Coming towards imaging, again imaging chest X-ray and USG thorax. Actually, the importance of USG thorax has been increasing exponentially in critical care medicine or recent years. Initially, USG was considered to be not good as ultrasound waves are a poor conductor of air is a poor conductor of ultrasound wave. But nowadays, using the artifacts that is produced by the air, we can identify a lot of conditions like atelectasis, pneumothorax, consolidation, pleural effusion, lot of things. I'm not going to details regarding USG thorax because it is out of it's a very vast topic in itself. So it is better that the PGs or postgraduate students get an understanding or hands-on training regarding the basic concept of USG thorax. It will be much helpful. And also, chest X-ray. Chest X-ray can be used immediately after intubation to assess the location of ET tube. Also, in case of any type of complication that is occurring, a chest X-ray is helpful. Here we can see on one of the image where there is a intubation into right mainstem bronchus, which may cause collapse of left lung, and if the ET tube passes much distally into the intermediate bronchus, even right upper lobe will be collapsed. So only functional lung that is remaining will be the middle lobe and lower lobe. So these types of things that we have always considered, we have to look at the position of the ET tube is very important. In case of males, it is placed often between 20 to 23 centimeter, and in case of females, between 20 to 22. The most important aspect now we are going is ventilator graphics. It can be considered to be almost the heartbeat of ventilator itself. So understanding the ventilator graphics is very essential. So this is a typical mechanical breath that is delivered by the ventilator. So this is a pressure time scalar. I will explain it in detail. So this is here is what there is initiation of breath that is occurring, and this TA represents the time of inspiration. Okay, and up to this much portion, this inspiratory time, and then this is the expiratory portion, and the total time constitute total breath time. Of variables, I think Neeraj has already explained regarding different types, that is trigger, limit, cycle, and all. So I'll just quickly rush through it. So trigger is the one that actually is the variable that causes breath to begin. So this is a trigger or the area where breath begins, and limit is the one that regulates the gas flow during the breath, and cycle is the one that causes breath to end or to change from inspiration to expiration. So trigger variables, there are different types of trigger variables: flow variable, flow trigger, pressure trigger, or time trigger. The target variable that controls the gas delivery during breath can be flow or pressure control. And cycle variable that cycles from inspiration to expiration can be volume, time, or flow cycling. So simply, once we are intubating a patient and the patient is sedated and paralyzed, initially what we do is we will set a respiratory rate of say 50. We are setting a respiratory rate of 15. What happens is that this is where the concept of time triggering comes from. Here, when we are setting a respiratory rate of 15, so the out of total 60 seconds, one breath will take approximately 4 seconds. So every fourth second, ventilator will deliver one breath. That is called as time triggering, which is triggered by the ventilator itself. Then coming towards the patient triggering. Patient triggering can be either pressure triggering or it can be flow triggering. So pressure triggering occurs when what happens is that when the patient tries to inspire, that means after the sedation has been weaned off and actually the patient have regained some level of consciousness, the patient will try to take a breath. So when patient actively inspires, there will be a pressure drop within the ventilator circuit, which can be identified from the pressure time curve, where there will be a negative deflection in the pressure time curve. So we can usually, what we say in the pressure triggering, usually trigger that we'll set is around 2 to 3 centimeter, 2 or 3 centimeter of water is the one that commonly we are setting. Or it can also be flow triggering. Flow triggering means here we set a flow of approximately 0.51 2 liter per minute. When the patient tries to inhale, there is some level of flow of gas that is occurring in the ventilator. When the patient inhales, this ventilator will sense the flow coming towards the patient side and it will deliver the volume. So there are two important triggers from the patient side, that is pressure and the flow triggering. So which is better, whether pressure triggering is better or flow triggering is better? When you ask that question, there are what I will say is that flow triggering is better when the patient's work of breathing is higher, because for initiating a breath by flow triggering, less effort is required compared to that of pressure triggering. So we can set either flow triggering or pressure triggering. But if the patient's work of breathing or patient is exhausted, it is better to go for flow triggering. The only disadvantage is it can cause increased auto triggering. Now coming towards cycling. Cycling is the point where it refers to end of inspiration. Okay, so it can be either time cycling or flow cycling. Means it determines length of inspiration and at what point the inspiration changes to expiration. So when it is time cycling, we will set the inspiratory time based on the Ti by T total ratio or IE ratio. And coming towards the flow cycling, so in a pressure flow cycling typically occurs in a pressure control breath. So I'm not going to detail regarding that, because most of the ventilator that we are setting that we are using in COVID ICU is volume control. Typically what we measure, we will set the TA level, this inspiratory time, and based on that the ventilator will cycle into expiration. Now coming towards the two important controlling parameter, that is volume controlling and pressure controlling. So volume controlling just simply means that we are setting a target volume and the pressure changes according to the, so volume is the one that we set, the pressure changes according to the pulmonary mechanics. Whereas in a pressure controlling, we will set the amount of volume of gas that is delivered to the patient depends upon the mechanics of the patient. So actually volume triggering is itself actually is a flow, for volume controlling itself a flow controlling, because here what we are setting is we are setting a specific tidal volume and we are also setting a time, inspiratory time. So this value will constitute flow. So actually most of the modern ventilators is what they are delivering is flow. Flow controlling is can be considered equivalent to volume control. And this is pressure controlling, where the specific pressure and depending upon the pulmonary mechanics, a particular volume will be delivered. So in short summary, there are three variables: triggering, cycling, and controlling. Triggering can be time, which is provided by the machine, or it can be pressure or flow, that is determined by the patient. Then there is cycling, which can be time or flow cycling, and then there is control, which can be volume or pressure control. So these are the various modes of ventilation. The most important one that we have to understand is control mode of ventilation. So I'm not going to details regarding various modes and details regarding the various different types of modes of ventilation. The most important thing that you have to understand is the concept of these scalars as well as loops. So this is the now we are going into the topic proper, that is the ventilator graphics. So ventilator graphics, there are two important concepts, that is scalars and loops. So scalars means a single variable is plotted against time. So either it can be a float time curve, a float time scalar, or it can be a volume time, or it can be a pressure time. And loops means there are two variables are plotted, one in x-axis and one in y-axis, which can be flow volume or pressure volume. So coming towards the first important scalar, that is a float time scalar. So in a float time scalar, the above the baseline, the flow that they are showing is the inspiration, and below the baseline it is the expiration. Okay. So the important components of a flow time curve we can identify is whether the patient is taking a spontaneous breath or a mechanical breath, the different types of flow patterns, and components of inspiratory and expiratory flow. And also we can determine various abnormalities that can be identified from a flow time curve. So this is a typical spontaneous breath. So spontaneous breath, typically the inspiration will be above the baseline, expiration will be below the baseline, and the it will produce like as a sign pattern. Okay, it will produce what is a sign pattern of breath will be produced by a spontaneous breath. Mechanical breath, again, inspiratory flow pattern will be above the baseline and expiratory flow pattern will be below the baseline. So in a typical, there are various different types of flow patterns that is seen, like the square form, the decelerating form, the sine form, and ascending form. Most of the case in a volume control ventilation, what we are using is a square waveform. There are importance for all different types of waveforms. Like in a square waveform and decelerating waveforms, there's a chance that the airway pressure will rise to a higher level compared to that of a sine or an ascending waveform, because there is a rapid increase in flow occurring that will lead to increase in airway resistance and increase in pressure buildup in the airways. Whereas a sine or ascending waveforms, this problem is not seen. The rapid increase in airway pressure is not seen. But we have to consider here is that what we are treating is the ARDS patients. So ARDS patients will be having a very high air hunger. So when the air hunger is higher, if we are giving an ascending or a sine type of flow, this patient will definitely be dissatisfied and will lead to asynchrony. So it's often better to give a square waveform or a decelerating waveform in patients with ARDS who is having high degree of air hunger. So this is a typical component of an flow time curve. This is a point at which the inspiration begins. The flow will rise to the peak inspiratory flow rate, then it will sustain at that level. Then once the time inspiratory time has completed, it will cycle towards expiration. Then expiration, there is peak expiratory flow rate also, and it will reach the baseline. So the entire inspiration and expiration forms the total breath time. So typically in a volume control mode, often square waveform is the one that is preferred and commonly used. Whereas in a pressure control and a pressure support mode, often there is a decelerating pattern is common. In pressure support mode, actually in a PSV mode, actually the for cycling also the flow, it is a flow cycle method. It means once the flow is decaying up to 25% of the peak expiratory flow rate, often it will cycle to expiration. Okay, you don't need to understand that much. Just consider that in a volume control, often the flow will be having a square waveform, and a pressure control mode and pressure support mode, it will be a decelerating pattern of waveform. Now, what are the uses of flow versus time curve? One is we can identify active inspiration and expiration, look for airway obstruction, we can assess the response to bronchodilators, look for air trapping and autopy. So expiration itself is a passive process and it's determined by the compliance of the lungs and resistance to airflow. So the 4 points that we have to observe during an expiratory limb is expiratory flow is peak expiratory flow should be assessed. Slope of expiratory time, and look whether the waveform has reached the baseline. So if we see a flow time curve with inspiratory portion having some sort of oscillations, means patient it is indicative of active inspiration during the when the breath is delivered. Then if the flow time curve, the expiratory portion fails to reach the baseline, means the patient is having some degree of air trapping. Okay, it is only seen in patient when there is some degree of obstruction, airway obstruction. Also, there will be a decrease in peak expiratory flow rate. Also, there will be prolongation of expiration. So you can see here there is an obstruction, some degree of airway obstruction that is occurring either due to bronchospasm in a COPD patient, or maybe due to secretions within the airways, or due to a kinged ET tube and all. So in that condition, what we had to look is peak expiratory flow rate. We had to look, and the peak expiratory flow rate, it will be reduced, and the expiratory time is prolonged. After a bronchodilator, we can see the peak expiratory flow rate has increased and the expiratory time has shortened. Also, if the patient is having airflow leaks, some leak is occurring in the circuit, what happens? The expiratory limb will rise above the baseline. Okay, expiratory limb will rise above the baseline, and the inspiratory limb also will fail to touch the baseline. So this is an example of autopeep that is occurring. Here, what happened? The expiratory limb. We can also identify it from the volume time curve where the volume failed to expiratory volume will fail to touch the baseline. But in the case of hot time curve, the expiratory limb will fail to touch the baseline that we have to consider. Now coming towards the volume time scalars. In volume time scalar, the basic components include the inspiratory tidal volume, the inspiratory time, inspiratory and expiratory phase. And the abnormalities that we can identify from volume time scalar is air leak and active air exhalation and autopeep. So this is a typical volume time scalar that is seen on a ventilator. So it has got an inspiratory component and an expiratory component. This is time taken for inspiration and the total time taken for the breath to be completed. Air leak is noted when the expiratory limb failed to touch the baseline. Okay, we can also estimate the volume of air leak from plotting it to this point. Similarly, if the limb extend, it can be due to active exhalation from the side of patient. The information is derived from a volume time scalar is air leak when the expiratory limb failed to touch the baseline. Active expiration, the tracing continues below the baseline, and autopeep when expiratory limb fail. Again, autopeep also occurs when there is some degree of air trapping. It's just to air leak also, because some of the amount of the inspired air is remaining within the lungs. That causes air trapping. In that condition also, the expiratory limb will fail to touch the baseline. Now, the most important scalar that you have to understand is the pressure time scalar. For pressure time scalar, the important abnormality that can be identified is the assessment of lung compliance and assessment of airway resistance. So, in a typical volume control ventilation, the pressure scalar will appear like this. It will be having more of a ascending limb will be more of a convex, and this will be a concave, and it will not touch the, if you are setting depending upon the PEEP applied, it will be above the baseline, and this much portion represents a PEEP that is applied by us. And in the case of a pressure control ventilation, the mode will be the pressure will be more of a square form. But as we are not using pressure control ventilation that much, you only have to consider volume control mode. Volume control mode where the curve, the pressure time scalar will appear like this. So this is a typical pressure time scalar, and as I already said that when the patient is triggering the ventilation, the pressure will dip below the baseline, which indicate active inspiration by the patient side, which is assisted by the ventilator. These are the various examples of spontaneous breath where the patient is inspiring, it will deflect below the baseline. I'm not going to details regarding this. The most important thing that we have to consider is what are the components of the pressure time scalar. This is very important. Okay, so the two important things that we have to consider here is the peak inspiratory pressure, the peak plateau, and the peak PEEP is the one that we are setting, and the peak inspiratory pressure will be shown in the ventilator screen itself. So there are various increases the peak inspiratory pressure that we have to consider. So peak inspiratory pressure is itself formed between it has got two components actually. It is formed due to airway resistance as well as the compliance of the lungs. It's actually simplified term actually to explain this in a single sitting is very difficult. So I will try to be as simple as possible. So the peak inspiratory pressure, that the pressure that is generated in the airway, is to overcome both folds as well as the elastic folds of the lungs. So any condition that increases the airway resistance or any condition that reduces the lung compliance will lead to an increase in peak inspiratory pressure. So how will we measure, how will you understand what is the reason for whether it is due to increased airway resistance or due to increase in decrease in lung compliance that is leading to an increase in peak inspiratory pressure. This is done by, there are two buttons that is present on ventilator. One is inspiratory hold and expiratory hold button. By pressing the inspiratory hold, what happens is that the inspiratory valve will close. Expiratory valve is already closed, so inspiratory valve will close. There will be no flow. Flow is the reason for airway resistance to occur. So as there is no flow, the pressure within the respiratory system is produced entirely by the compliance of the lungs. So what happened? The pressure, once we press the inspiratory hold maneuver, the peak inspiratory pressure will fall towards a P plateau level. So P plat demonstrates the compliance of the lungs, and the difference between the peak inspiratory pressure and the P plat represents the resistive part of the curve. So this is the same diagram I am representing. So any condition that increases the difference between the P plat and P peak, that is due to increase in airway resistance, and any condition that increases the P plat may be due to a decrease in lung compliance. So as we all know that compliance is actually inverse to elastance. Okay, or compliance can be considered as change in volume divided by change in pressure. That means when the compliance is low, means to produce a unit change in volume, a higher degree of pressure have to be produced. For example, in ARDS the compliance is very low. So compliance is very low, so we have to generate a maximum amount of pressure to produce a desired change in volume. So whenever condition that can cause a reduced compliance can be pulmonary or extrapulmonary causes. Main pulmonary causes may be ARDS due to viral pneumonia, as we are finding out. Atelectasis, consolidation, tension pneumothorax is another one. So a patient who is suddenly deteriorating on ventilator and we are seeing an increase in peak inspiratory pressure, we are pressing the inspiratory hold and we are seeing that the peak pressure, the plateau pressure is much higher. That means there is a chance we have always ruled out presence of tension pneumothorax for that patient. There are the extrapulmonary causes that increases the complaint: abdominal distension, chest wall edema or obesity, thoracic deformity and all. So this is the thing. So this is a normal condition where there's a peak inspiratory pressure, there's a plateau pressure. Peak inspiratory pressure can be increased due to both these conditions, either due to high in airway resistance or due to a low compliance. If there is a high airway resistance, after pressing the inspiratory hold on ventilator, if the plateau pressure is within the normal limit, but it is the difference between plateau pressure and peak inspiratory pressure that is elevated, means the patient is having some degree of airway resistance. On the other hand, if we are on inspiratory hold maneuver, if the airway resistance is lower, the plateau pressure is on the higher level, it means it is a problem with a poor compliance of the lungs. So as I already said, plateau pressure can be increased by all of these conditions, and airway resistance can be increased due to some degree of airway obstruction that can be due to secretion of mucus plugging or bronchospasm. Even an ET tube that is small in size will significantly increase the airway resistance, or a blocked ET tube in ventilator circuit if there is kinking or clogging of HME filter, again we have to consider. Okay. Again, inadequacy of flow can also be identified by a pressure time scalar when there is a curvature that is coming inside. That means there is a flow that has been set by us is considered to be very low. Now coming towards the loops, so we have seen three scalars. There is the flow time scalar, the the volume time scalar as well as the pressure scalar. Now coming towards loops, there are two loops. One is pressure volume loop and the flow volume loop. So pressure volume loop, pressure is plotted in the y-axis and volume is plotted in the x-axis. The abnormalities that can be identified is decreased compliance, airway resistance, alveolar distension, and air leak. So this is a typical spontaneous breath. So in a spontaneous breath, it is always going in a clockwise direction. So always in a clockwise direction. Here what happened, the inspiration, since it's a negative pressure breathing, inspiration will be towards the negative side. So once inspiration, the expiration occurs. So it is always in a clockwise direction. Whereas in the case of an mechanical breath, that is a controlled mechanical breath, it is a positive pressure ventilation. So it always runs in an anti-clockwise manner. So what happens is that this is inspiration that is occurring, and this is expiration that is coming down, inspiration and expiration. And when it is assisted breath, what we can see is that there's inspiration that is occurring and expiration is coming, it touches the baseline. After that, the patient will do the effort. Patient is so what happens is that there is some degree of occurrence, then it will again come out, which is assisted by the ventilation. So these are the different, just to give a briefing, this is the pressure volume. Here volume is plotted and here the pressure is plotted. Okay. So the components of a pressure volume loop is this. Okay. So this is the inspiratory loop and this is the expiratory loop. There is always some degree of hysteresis. There is a difference between inspiration and expiration even in a normal. That is because of the viscoelastic properties of the lungs. Inspiration and expiration always will be having some degree of hysteresis. Hysteresis means some degree of area will be present between these tools. Okay, so this is an important diagram that is very essential to understand the concept of compliance and all. So what happens is that once the inspiration begins, especially in like a patient who is having ARDS and all, majority of the alveoli are in a non-recruit. Non-recruit means already collapsed alveoli because surface tension is low, the alveoli are collapsed. What happens is that we are increasing the pressure. As the pressure increases, the change in volume is very low because the patient is having a very low compliance. We already know that compliance is change in volume by change in pressure. So to create some degree of change in volume, very high pressure is required. But once a critical point has been attained, which is known as the lower inflection point, what happens is that rapid alveolar recruitment or alveolar distension occurs. So the curve will rise. So here we can see the slope. The slope here is more acute. Here the slope was less acute, but here the slope becomes more acute. That means compliance is much more higher. So even with a minimal change, we can see that for if we are comparing to pressure here, the volume that is generated was much lesser. But for the same amount of pressure, we can see there is a drastic increase in volume that we can produce. So this portion is the most compliant. It will be an increase in inflation of the lungs till it reaches a point that is known as the upper inflection point. So upper inflection point means already the recruited alveoli are completely distended. Now what happens if we further increase the pressure? There will not be much change in volume because what causes it will cause the distension of already distended alveoli that will produce what is known as beaking. Okay, that is known as beaking, which is very important. We can identify if we are identifying the volume pressure loop or over distension and can lead to barotrauma, can lead to pneumothorax, can lead to hemodynamic compromise, etc. Okay, so that is the graph. This is during inspiration. During expiration, what happens when the pressure gradually reduces, since the alveoli are already recruited, there will not be much change in volume. But as the volume reduces to a critical, pressure reduces to a critical level, what happens? There will be sudden de-recruitment of alveoli occurs, and the alveoli will collapse, and it will come back to the functional residual capacity. So identifying this lower inflection point is critical because according to this lower inflection point is by which we are setting the peak expiratory, we are setting the PEEP, okay, for adequate alveolar recruitment. Now coming towards the different types, in a case of volume control ventilation, we already know that tidal volume remain constant, but the pressure is the one that is changing. So the volume will, the curve will appear like this, loop will appear like this, the volume will be constant, the pressure will be changing. Whereas in pressure target ventilation, the pressure will be constant and the volume will change. And this is a important diagram, flow volume loop, that we have to understand. So what happens is that the first we will see with the volume control ventilation. In volume control ventilation, you can see here this green loop that is shown is the normal. So in case of volume control ventilation, we will set target volume and the pressure changes according to that. So once the target volume is attained, the peak inspiratory pressure that is seen is this much, that is within a normal limit. But when the compliance of the lung reduces, what happens? The curve will shift towards the right side. That means a much higher peak inspiratory pressure will be generated to produce that much tidal volume. Whereas in a highly compliant lung in COPD, even the pressure generated is much lesser compared to that of a normal lung. So the curve will shift towards the left side. Whereas in a pressure targeted ventilation, again, we are setting a preset peak inspiratory pressure, and the amount of tidal volume generated depends upon the pulmonary mechanics. So a patient who is having a very emergency, if we are setting a preset peak inspiratory pressure, like for example 30, if we are setting 30 centimeter of water, we can see that the amount of tidal volume that is delivered varies according to various conditions. For normal individual, it will reach around normal limit, but in a highly compliant lung, the same amount of peak inspiratory pressure will produce a large amount of tidal volume because lung is highly compliant, whereas in a patient who is having ARDS or compliance condition where compliance is reduced, a low tidal. So again, this is an ARDS lung, which another thing that we have to consider is a normal lung also some degree of hysteresis will always present. But the pressure volume loop will be almost linear, but some degree of hysteresis will be present owing to the viscoelastic nature of the lungs. Whereas in case of ARDS, the hysteresis will be much more wider. The wider the hysteresis, more recruitable the maneuver is. Especially in early ARDS, the picture will appear like this. Okay, the recruitable will be lesser, but in higher recruitable will be higher, so the hysteresis will widen. So when the patient is having a wider hysteresis, recruitment manuals can be done. I'm not discussing the recruitment manuals because it is again out of scope of this session. Again, assess the curvature. Also, we can see if the linear compliance is lower. That means if the curve is less steeper, recruitability is lesser, but if the curve is more steep, means recruitability is higher. So you have to consider this thing. If there is a wider hysteresis loop, or if the slope is much more higher, by increasing the PEEP and all, we can increase the oxygenation of patient. Again, another important concept that you have to consider in a flow, in a pressure, in a volume pressure loop is the area under this portion, up to this portion, is constituted by the inspiratory resistance, and this much portion is produced by the expiratory resistance. So any condition that can increase the inspiratory, shift the hysteresis towards this side. Okay. This side, and any condition that increases the expiratory resistance, the curve will be shifted to this side, and the remaining portion is formed by the elastic property, that is compliance. So whenever there is a low compliance occurs, as I already said, the hysteresis will move extremely towards the right side. And again, over distension can be identified if there is weak of the inflection, important. And air leak can be identified when the pressure volume loop failed to, the expiratory limb failed to touch the baseline or failed to reach the FRC. And now coming to its flow volume loop. So in flow volume loop, we already have studied flow volume loop in spirometry. But in spirometry, it is actually entirely opposite. That means expiration will be above the baseline, inspiration will be below the baseline. But in a positive pressure ventilation, inspiration will be above the baseline, expiration will be below the baseline. We can calculate the, just like a spirometry, we can calculate the peak inspiratory flow rate, peak expiratory flow rate, and all. So again, in a volume ventilation, the graph will the curve will loop will appear like this. The volume will be constant during inspiration, whereas in a pressure control, the volume will be variable during both inspiration and expiration. Then, through this, we can identify two important pathologies. One is air leak. So if the expiratory limb failed to touch the baseline, there is degree of air leak is present, which we can measure it. Or if it touches the baseline here, it may be due to air trap. Okay, it may be due to air trap. Also, we can assess the bronchodilate response. If there is some degree of airway resistance, the expiratory limb will always have a scooped out appearance, and the peak expiratory flow rate will be reduced. But in this case, what happens is that after bronchodilator, the scooped out appearance will be reduced, the flow rate will be increased. So these are the ways by which we can diagnose conditions. Okay. So depending upon the modes of ventilation, which waveforms you have to monitor. So in a volume control or assist control mode, as Neeraj has already said, what all variables that we are setting, we will set a tidal volume, we will set a respiratory rate, we will set a peak expiratory flow rate, we will set the I ratio. Depending upon these and depending upon the lung characteristics, the airway pressure will change. Okay. In a pressure control mode, on the other hand, we will set the airway pressure, inspiratory time, PEEP, and IE ratio. And depending upon the lung mechanics and the applied pressure, the tidal volume as well as the tidal volume will change. So the important waveforms that we have to monitor in a volume control mode is pressure time curve, the most important thing. Then there's flow time curve and there's a pressure volume. These things we have to monitor to assess the performance of the patient when connected to a ventilator. So the common problems that we can diagnose by analyzing the waveforms are abnormal ventilatory parameters or lung mechanics, the patient-ventilator interaction, and ventilatory circuit-related problems. So once again, increased airway resistance in an assist control, volume control ventilation, we can identify it by assessing the pressure time waveform. There will be increased between P peak and P plat. Okay, pressure time. What happens in pressure time? There will be a drastic fall occurs. There will be drastic fall occurs from P peak to P plat. P plat will be normal, P peak will be elevated, and the difference between P plat and P plat will be higher. Expiratory flow waveform, there will be a decreased peak expiratory flow rate, increase in expiratory time, scooped out appearance of expiratory limb. Also look for the potential for PEEP, auto PEEP, and the volume expiratory limb will be longer. So this is a patient with an endotracheal tube block. We can identify that the peak inspiratory pressure has reached up to 50 and the plateau pressure is on lower side. So this much portion is constituted by the airway resistance. Okay. Now decrease complaints of respiratory system. It can be assessed again from the pressure time waveform where the P peak as well as P plat will be elevated, but the P peak minus P plat value will be in normal limit. And the flow time waveform, there will be increase in peak, there will be a shortened expiratory time. Again, in the expiratory limb, if we are seeing oscillations, it's most commonly due to secretions within the airways. Then we have to suction the airways. Then again, over distension of lung can be identified when there's an increase in P peak and P plat with a high expiratory flow rate. That is indicating of over distension of lungs. Again, we can calculate the stress index. Again, I'm not going into details regarding that. Now, a few concepts regarding the concept of auto PEEP. So auto PEEP is an unintentional PEEP that occurs during mechanical ventilation when a new inspiratory breath begins before the inspiratory flow has ended. So suppose a patient is taking a breath and before it touches the baseline, another breath he is taking. So breath keeps on stacking on itself. Instead of reaching the FRC, it is not reaching the FRC, the breath keeps on stacking on itself, leading to a trapped volume. So what are the various physical factors that causes auto PEEP? So auto PEEP can occur without hyperinflation, with hyperinflation. Auto PEEP without lung hyperinflation or lung distension is actively expiring. Okay, active recruitment of expiratory muscles. But these two conditions that can occur without and with airway obstruction, it can cause dynamic hyperinflation. Okay, so one of the common reason is COPD. Other condition that is typically associated with auto PEEP is an increase in respiratory rate, shorter inspiratory time, using multiple end inspiratory pause, or using a small endotracheal tube, ventilator going some degree of obstruction. All these conditions can lead to air trapping. So factors that increases the risk for auto PEEP are COPD, high minute ventilation, age more than 60, increased respiratory rate, shortened expiratory time, increased tidal volume, and increased air resistance. So the most common thing that we have seen is, and especially in COPD patient, there is an increased risk of air trapping. Another one is increase in respiratory rate. So if the patient is having a respiratory rate of say 30, so his entire inspiration expiration, so it's single breath cycle. So you have to inspire and expire within 2 seconds. So suppose patient is taking an inspiration of 1.1 second, he may get only 0.9 seconds for expiration. That may lead to what? That may lead to air trapping. So, increased respiratory rate, COPD, these are the common clinical conditions that we often see that lead to autopsy formation. So autopsy can be easily identified, as I already said, that by assessing, looking at the flow time curve. If the expiratory limb failed to touch the baseline, some degree of how to measure the autopsy. We already said there is one button that is the inspiratory pause or inspiratory hold. Similarly, there is one more button in the ventilator that is called the expiratory hold button. So by pressing the inspiratory, ideally this should be done when the patient is completely sedated, paralyzed. So expiratory hold, by pressing the expiratory hold, what happens? The expiratory limb will close. Okay, expiratory limb will close. So the amount of pressure that is present within the alveoli will be equate with the ventilator circuit, and we can measure the amount of pressure within the alveoli at the end of expiration. So that total PEEP total that will be obtained will be equal to the applied PEEP that we are applying plus the auto PEEP that is present. So by subtracting the applied PEEP, we already know, suppose a total PEEP comes to be around 7 and we are applying a PEEP of 5, means there is 2 centimeter of auto PEEP that is present. So what are the consequences of auto PEEP? One, it increases the work of triggering, which I will explain. It can lead to ineffective triggering, cause barotrauma, hemodynamic compromise, hypotension, and all. It can even lead to pneumothorax. So this is one important diagram that I have to show how it increases the work of breathing. Suppose we haven't set a PEEP set ചെയ്തിട്ടില്ല. We haven't set a PEEP. PEEP നമ്മൾ സെറ്റ് ചെയ്തിട്ടില്ല. We have set a trigger. നമ്മൾ trigger സെറ്റ് ചെയ്തിരിക്കുന്നത് 2 centimeter of water ആണ്. So patient have to generate a negative 2 centimeter of water to trigger the breath. Suppose there is an auto PEEP. If auto PEEP on the 6 centimeter auto PEEP, what happens? The patient have to generate 8 centimeter of water to trigger that breath. So imagine the amount of work required by the patient to overcome that. So in this way, it can cause condition. It can increase the work of breathing. It can cause asynchrony. It can cause delayed. It can also cause ineffective triggering. Okay. So how will you treat auto PEEP? One is we can change the ventilator settings. That is, we can give adequate time for expiration. We can increase the expiratory time, decrease the respiratory rate. Okay. Then reduce the ventilator demand of the patient by adequately sedating the patient. Reduce the flow resistance. Often at least use an 8 or 8.5 centimeter, 8.5 for and males and females 7.5. Okay. If you are using a small ET tube, it often lead to increase in airway resistance. Also, we can give bronchodilators and suction frequently. The final thing that we can do here is we can counterbalance by applied. This should modality that you have to use, because when we are putting an applied PEEP along with an auto PEEP, the total PEEP generated will be such higher that may lead to hypotension and barotrauma. So also we have to consider that the applied PEEP should always be less than 85% of auto PEEP that is calculated. So how does it function? So again, here the same patient, the trigger sensitivity is 2 and auto PEEP is of 6. We are applying a therapeutic PEEP of 5. What happens is that it will reduce the auto PEEP so that the patient require of water to trigger the breath. But only problem is that the total PEEP now will reach 11, and that can lead to further complications. So that should be the last resort. Now coming towards troubleshooting. So troubleshooting involves identification and resolution of technical malfunctions in a patient ventilator system. So how to assess a patient showing respiratory distress when connected to ventilator? So we have ventilated the patient, we have monitored, everything is well and good, but suddenly patients start deteriorating with no reason. So how will you assess whether the patient is deteriorating? Visually examine the patient. If there is a change in the GCS, there is use of accessory muscles, or there is change in chest wall movement, the patient is diaphoretic, anxiety. Obviously, we can auscultate the patient if facilities are there. We can assess if the saturation is falling, if there is a tachycardia, if there is tachypnea, if there is hypertension. All these 3 conditions can be used to assess the respiratory distress in a patient. So the causes of sudden respiratory distress in a mechanically ventilated patient can be patient patient-related causes, letter-related causes. So patient-related, there are a lot of causes. It may be due to an airway problem, ET tube may be defective, ET tube may be migrated or may be blocked. It may be due to bronchospasm, secretions. It may be due to other conditions like pulmonary embolism, pulmonary edema, okay, pneumothorax, anxiety, all these conditions. Or it can be due to ventilator-related conditions. It may be due to ventilator asynchrony. It can be due to circuit malformations or disconnection, maybe an O2 supply that has been down. All these conditions may lead to sudden deterioration. So how will you treat the patient? First of all, we have to disconnect the patient from ventilator and we have to give an ambu bag with 80 to 100% oxygen. So if the patient's condition improves by bagging the patient, okay, that means the problem is with the ventilator. Okay. Otherwise, the patient will not improve. Also, by bagging, we can assess if there's an ET tube blockage is present. We can also indirectly assess the compliance by assessing the field. If there is significant resistance to ambuing, we can assess such type of conditions also. And meanwhile, we have to rapidly examine the patient and assess the indexes and alarms, check the patency of airway by passing a suction catheter. All these things that you have to assess. So there are various causes of airway problem that can lead to sudden respiratory distress, like migration of ET tube both above and below, cuff rupture or leakage of ET tube cuff, patient biting the ET tube, airway secretions, and basically with what are the ventilator induced problem. Okay, so the patient ventilator asynchrony. So there is a synchronous ventilation occurs when ventilator responds appropriately to a patient's inspiratory effort and delivers the amount of flow and volume required by the patient. So it is otherwise considered to be what is known as fighting the ventilator. So there are different types of asynchrony that is seen. One is trigger asynchrony, other one is flow asynchrony, cycle asynchrony, mode asynchrony, peep asynchrony, and all. So I'll just basically superficially deal with this. So trigger asynchrony can occur due to ineffective triggering, auto triggering, double triggering. At least we have to understand between ineffective triggering and auto triggering and all. So ineffective triggering is one of the most common asynchronies. Here there is failure of patient's inspiratory effort to initiate a ventilator breath, which can be identified with visual inspection of patients expanding thoracic volume but without delivery of ventilator breath. The ventilator graphics which shows airway pressure with an increase in flow, but there will be no initiation of breath. So it can be identified easily by assessing the pressure time scalar and the volume time scalar. So in the pressure time scalar, there will be negative deflection in the pressure wave, but there will be no flow happening. Flow also slightly increases in the side of patient, but the ventilator will fail to sense it and will fail to deliver it. Again, similarly, here also in a volume pressure loop also, what happens is an inspiration occurs, an expiration occurs, the patient will try to inspire. So it will cause a negative deflection of the pressure curve here. But and actually the deflection will pass below the set level of PEEP. That means the trigger has not been sensed by the ventilator. So this is called what is known as the fishtailing appearance. Okay, fishtailing. So most importantly, you can assess this by assessing the pressure time scalar and flow time scalar. So what are the important causes of a trigger asynchrony? Is improper sensitivity of trigger threshold, respiratory muscle weakness, intrinsic PEEP in a COPD patient. I have already seen that auto PEEP will cause ineffective triggering, decreased respiratory, okay, and usage of high tidal volume or high pressure support that decrease respiratory. Next is auto triggering. Auto triggering means ventilator delivers an assisted breath that was not initiated by the patient. It is particularly common if we are setting a very low threshold. Like for example, if you are setting a pressure threshold of say 0.5 or 1 centimeter of water, or a flow of 0.5 or 1 liter per centimeter, 1 liter per minute and all, that can lead to even cardiac oscillations or fluid in the circuit to sense it as a change in the flow or pressure that may lead to delivering a breath. So what happens is that the normal inspiratory dip on the pressure curve will not be seen here, and the ventilator will deliver air breath. So for the patient, it will lead struggling with the patient. So one of the important reasons for an auto triggering is due to leakage. So leakage can be identified by pressure volume loop or by a flow volume loop where the expiratory limb failed to touch the baseline. Okay. Now coming towards flow asynchrony. Flow asynchrony occurs when inspiratory flow from ventilator does not matches the patient's effort. That means during inspiration, the flow that is produced by, suppose we are giving an ascending patient may not, patient is having severe air hunger. These types of patterns flow asynchrony is typically seen in ARDS patient. Due to severe air hunger, if you're giving an ascending ramp, what happens is that the patient needs much more higher flow rate rather than that. So what happens? The patient will try to actively inspire, that may lead to a dip in the pressure. So it will produce a dip in the pressure time scalar that will produce an M pattern on the pressure time scale. Similarly, so that is how we identify the flow asynchrony. Okay, so flow asynchrony, what we can do is that if patient is having ascending ramp of flow, or if the patient is having a square waveform, we can convert it into a descending pattern so that a higher flow will be delivered to the patient quickly. Now coming to cycle asynchrony, it can be premature cycling or delayed cycling. So premature cycling means we are holding inspiratory time. So when the ventilator inspiratory time is less than the patient's neural inspiratory time, means patient inspiratory effort will continue into the expiratory phase of ventilator birth. So what happens is that here the patient will continue to breathe even when ventilator starts exhaling. Patient will try it. So what happens? The pressure will characteristically dip below the baseline, by which we can identify pressure cycling. How to treat? We can prolong the inspiratory time or adequately sedating the patient. Then delayed cycling means the ventilator inspiratory time is higher than patient's neural inspiratory time. Means ventilator continue inspiration when actually expiration has been started for the patient's side. So what happens is that the ventilator is continuing inspiration or giving the flow, but patient is started exhaling. So what happens? The sudden exhalation will cause a pressure to rise and a sudden fall in peak expiratory, sudden fall in the flow time curve. So in this way, we can identify what is of the delay cycling. So these are the various different types of asynchrony. Now another important aspect is assessment of ventilator alarms. Whenever we are entering in ICU, we are often welcomed by various different types of alarms that is happening in the ICU, and alarms should never be ignored. Always we have to check what is the reason for the alarm, and we have to take appropriate action. So alarms can be low pressure alarm, high pressure alarm, apnea alarm, high frequency, high respiratory rate alarm, or high minute ventilation alarm, IE ratio alarm. Different types of alarms are there. So common causes of low pressure alarm: sudden drop in pressure with the ventilator circuit may be due to disconnection, circuit leakages, or disconnection of inspirator or expirator tubing of ventilator circuit, exhalation wire leak, airway leaks due to any rupture of ET tube or leakage from the ET tube cuff, etc. So what are the common causes of high pressure alarms? High pressure alarms can occur means the patient is having an increase in peak inspiratory pressure. So this is again commonly seen in patients with ARDS who are going into severe ARDS stages. So it can be due to, as I already said, the peak inspiratory pressure can be due to an increase in airway resistance or maybe due to a decrease in complaints. So conditions that can increase the airway resistance like coughing, secretions or mucus in the airway, or some degree of ET tube blockage, or conditions like bronchospasm, mucosal edema, or decreased complaints like pneumothorax, pleural effusion, or severe ARDS, patient ventilator asynchrony. All these conditions can lead to high pressure alarms. So what is the algorithm by which we can assess it? So algorithm basically is, in a case, low pressure. So this is algorithm for a low pressure alarm. So low pressure alarm is detected. First of all, we have to verify the patient stability and adequacy of ventilation. First of all, check whether the patient is disconnected from the ventilator. Okay, if the patient is disconnected, we can reconnect. Look for leakage in the patient circuit. Assess the cuff leakage. Even there are various machines that is available to assess the cuff pressure, adequacy of cuff pressure. Ideally, the cuff pressure should be set between 20 to 30 centimeter. So if the cuff pressure is not adequate, can lead to assess the cuff pressure, or assess the cuff leakage is present or not. Also, if the patient is having chest tube, if there is excessive air leakage through chest tube, Look for the proximal airway pressure line obstruction. And ultimately, if none of these things is faulty, look for flow sensor malformation. Flow sensor malfunctioning, we have to sometimes may have to call the biomedical to recalibrate it. Also look at the alarm setting. If it is properly, alarm is in the, sometimes alarm may spontaneously get inappropriate settings. So assess the if the alarm has been properly set or not. And if all checklist has been completed, we again have to contact the biomedical to look for any other possible causes. When high pressure alarms or high PEEP alarms are being high is started to sound, we first of all look at the any obstruction for ET tube, any obstruction in the ventilator circuit, secretions within the ventilator circuit has to be identified. If there is obstruction, we can suction. If there is secretions, also we can suction catheter can be passed. If the patient is biting, an oral airway or a bite block can be applied. Okay, or we can press, if all these things are negative, we can obviously press the inspiratory pause button to assess whether it is due to an increase in airway resistance or due to a reduced compliance, and you have to treat accordingly that. Also assess whether there is some degree of asynchrony that is occurring, that is due to a high pressure. If there is some high degree of asynchrony, we can even sedate and paralyze the patient. Assess for autopy, which will also cause an increase in pressure. Okay, if there's autopy detected, we have to treat the autopy as I already explained. Also, if all these things are normal, we have to assess if the exhalation valve is malfunctioning. In that case, we have to call biomedical. Also, if you always look at the alarm setting, also if it is appropriately placed or not. Then, if there is a high net ventilation alarm that is occurring, assess the flow demand of the patient, and we have to adjust the flow according to that. If there is auto assess, change the trigger setting accordingly. Also, we have to assess whether the flow sensor is functioning properly or not. Or finally, we have to assess whether the alarm settings are appropriate or not. Now, coming towards the IE ratio. Actually, there is a concept what is known as the inverse ratio ventilation, which is primarily applied in case of a refractory hypoxemia in ARDS. I'm not going into details regarding that. IE ratio, inverse IE ratio means inspiratory time will be higher and expiratory time will be low. Normally, what we are setting is 1:2 or 1:3 ratio, but here inspiratory time will be increased. So whenever we are changing an IE ratio to a reverse inverse ratio, typically an inverse ratio alarm will sound. But if we are doing it for refractory hypoxemia, it's well and good. Otherwise, we have to check the inspiratory time, and we have to reduce the inspiratory time if it is due to the problem, or if it is due to some volume. If the patient is on volume control ventilation and the flow is too low, we can increase the flow. If the flow is increased, naturally the inspiratory time will reduce. If volume ventilation is used with high volume, also we can decrease the volume so that time of inspiration will be reduced. And if the respiratory rate is very high, we can reduce the respiratory rate. So if all these problems have been checked, and if it is also, we have to assess whether there is increase in airway resistance or decrease in compliance also. And we also has to check the alarm settings, see if it is appropriately set or not. Now coming to apnea alarm. So apnea alarm particularly occurs especially when the backup respiratory rate has been set to a very minimal. Usually in a volume control mode, we often set the respiratory rate in 15 or 16. So the chance of apnea alarm is much more lesser here. It's particularly seen in pressure support ventilation or an SIMV mode, where the SIMV rate has been reduced to a low value, where the patient triggered breath is very minimal. So again, we have to look at the appropriate alarm settings, whether it is appropriate or not, or if the ventilator is insensitive to the patient effort, we have to reset the sensitivity, assess for leak if a leak is present or not, and also we have to look at the sensors. And last and most important is sometimes we will fail at that moment when the patient is suddenly becoming bad and we intubate the patient and connect it to ventilator. We often forget to connect the ventilator to the power supply. So very important that we have to check adequate battery is present and the ventilator is properly connected to an AC supply. Also, the compressor should properly function. Sometimes what happens is that there will be especially when the oxygen demand is higher in multiple ICUs, what happens, there will be a sudden drastic fall in the central line pressure that may lead to low oxygen pressure, and sometimes the compressor may also fail. So in that condition, we have to disconnect the patient from ventilator, and we have to give mask. We have to give the ambu ventilation. Okay. So the most important, once again, I am stressing is the pressure time curve that you have to consider. It's very important, especially in ARDS setting that I am saying. So any patient who is acutely deteriorating, look at the peak inspiratory pressure. If the peak inspiratory pressure is reduced, it may be due to air leak or hyperventilation. If the peak inspiratory pressure is increased, always go for the inspiratory hold maneuver, assess the plateau pressure. If the plateau pressure is increased, that means there is due to reduced compliance. Get an X-ray possibly. Also look for evidence of surgical emphysema, pneumothorax, assess the chest movement. Okay. If the plateau pressure is normal, but the difference between inspiratory pressure and plateau pressure is the one that is increasing, always look for airway obstruction. It can be due to aspiration, bronchospasm, secretions or tube block, or if peak pressure is also unchanged, we have to look for other possible conditions. So I'll just, this is an example, just one question I'm asking. So it's a 28-year-old man who is receiving ventilator support and volume controlled ventilation. High pressure alarm has been activated several occasions for the past 4 hours. Okay, the patient was admitted 72 hours earlier following a motor vehicle crash in which he sustained chest trauma without pneumothorax. He had been receiving ventilator support for past 36 hours because of severe hypoxemia and increased work of breathing that has progressed to acute respiratory failure. So at a particular time, the respiratory therapist bilateral crackles, particularly in lung bases, where percussion not was done. A chest radiograph show bilateral infiltrates. So what we can identify here is that his tidal volume, we have interval one, so tidal volume that we have set is 0.5, 500 ml. You can see that initially the peak inspiratory pressure was 25, but it gradually increased to 39. And on assessing the plateau pressure has already increased. Okay, but so we can see that here the peak inspiratory pressure has increased, the plateau pressure has increased, but the difference between peak inspiratory pressure and plateau pressure is remaining normal. So that means there is some degree of it's basically because of reduced compliance. So one possibility is patient confusion leading to ARDS, or maybe due to a late onset pneumothorax. So always you have to consider these possibilities in our mind while examining the patient at bedside and assessing the ventilator graphics. So to summarize, it's important to identify the correct waveforms to monitor the patient, spend more time at bedside, never ignore any ventilatory alarm, monitor the P peak, P plat, and expiratory limb of flow volume to diagnose changes in lung resistance or compliance, and identify dysynchrony early and correct the cause. Thank you. Thank you, sir. I think the time has exceeded 1 hour, I think. Any questions?
Mubarak sir undo Arjun?
Hello, sir. Sir.
Mubarak sir undo? Mubarak sir undo? Mubarak sir. Okay. If there are any questions, you can either ask directly or put in the chat box.
I think you'll get